This conference will now be recorded.
So welcome everyone to this edition of Journal Club. This is a special Journal Club where we're going over the NAEMSP Airway Compendium. This was a document that was published by the National Association of EMS Physicians. Presenting today will be our EMS Fellows, Dr. Ano, Dr. Chowdhury, Dr. Deacon, Dr. Shi, and Dr. Yoon. Let me move. So the Airway Compendium is kind of a conglomerate of a couple of physician statements, as well as some review of the current literature and, what was controversial. They avoided things that were basically already out there where it's known practice. So, do we intubate or not intubate is not necessarily something that they went into, but, talking about, delayed sequence intubation, or delayed airway management, things like that, difficult airway, things like that. Do you use a supraglottic? Do you do this? So those are kind of the things. There's an entire section just on quality improvement, quality management, which is excellent. And then they also go into specifically into pediatrics. One of our former graduates is actually one of the leads on that as well, Dr. Harris. Association recommending best practices, including training, quality management techniques, disease-specific considerations, and what evidence is actually out there. I think it's important that you also think about, the reason why this was important was because some of the position statements that we put out are from back in the 1990s, and that was when RSI was considered. Is this a good idea? Is this not a good idea? How do we learn from each other? How do we learn from ourselves? And how do we monitor and make things better? Jesse, you want to say anything else about that?
Yeah, sorry about that. I had multiple speakers on apparently. All right. Yeah, so this is kind of a generic introduction. They had an introduction piece in the beginning before all the position statements that essentially highlighted what the ending of what Navin just said. What they wanted to do was basically readdress all the prior position statements that they had, and then also make new ones, especially with how technologies have been advancing and a lot of the new research has come out, and this is a good way to consolidate everything. So this was the NAEMSP's overall recommendation for best practices, and it touches on all these things on the bottom there: training, quality management techniques, disease-specific physiology and what you should consider, and they added a pediatric section towards the end as well. So that's what we're going to be talking about. All right. So my part is going to be the first three position statements, and I have the pages there highlighted for you as well if you want to follow along. And we can go ahead with the first one. Want to click next, Navin? Or are you able to go back to the slides? Oh, there we go. And then just next slide. There we go. All right. So how these position statements will be broken down is each one has anywhere between, I think it was between 3 to 7 recommendations that they officially stated. And then each recommendation had a backup set of evidence, resource documents, and different things that we're going to go over. So the very first one, the first two addresses training, education, and quality management, essentially. So this first paper was titled Pre-Hospital Airway Management Training and Education. The first recommendation that they touched upon was active engagement in deliberate practice should be guided approach for developing and maintaining competence in airway management. So this was a huge topic that they talked about over and over again, and that development of clinical airway skills is a huge overall competency for both BLS and ALS providers. And they really wanted to emphasize that it needs to have a knowledge of strengths and weaknesses of the different techniques you're going to use to essentially challenge what kind of clinical decision making you're going to have. They summarize into 3 different domains: a psychomotor one, cognitive one, and affective one. So specifically talking about this first recommendation, they continue to use this quote deliberate practice a lot. And what they mean by that is that they want us to be able to have well-defined goals every time you want some sort of airway management education. This means that you have some sort of ability to implement a comprehensive airway management by constantly having reproducible quality no matter what kind of condition you're in. And that's what EMS is, right? You have different diversity of conditions. You want to make sure that the quality of medicine you're giving is consistent. These fundamental concepts, you want to make sure you have proficiency with them and that both your task and the components that you're utilizing have reproducible nature of it. And a lot of traditional education and mindset has been that you can use your clinical experience from it, but they highlight that clinical experience in different EMS agencies are just so vast that it's unreliable. It's unreliable in frequency, and it's also unreliable in the kind of skill set you may be choosing, and you might also develop bad habits and not realize it. So that was something important to keep in mind. That growth that you have from a minimally competent to an advanced competent provider requires that conscious effort to improve both the skills, but you also want to work on developing models and mental incorporations into your head that can have the complexities of both the pathophysiology. You want to have team dynamics in it. You want to have evidence to be able to back up more than just relying on your clinical experience. So they kind of summarize all that by saying it needs to be a deliberate practice. And that deliberate practice, they were able to also highlight the 3 conditions. And that actually those 3 conditions, if you have the paper, was on table 1. The first one being having a focused instruction, that so you have specific goal tailored to your level of learner. The second one was that learners can receive detailed and immediate feedback on their performance. And they actually give examples on each of these 2 right there. Yeah, table 1. The third component being that learners have opportunities to improve their performance by performing the same or similar task repeatedly. So this is what they highlighted as that deliberate practice element, so that you have that goal orientation and makes it easier to evaluate someone, makes it easier to manage someone, it makes it easier to educate someone. So that you can see the examples on the side there for each of these steps. They're pretty well done.
And we all know from our own practice that this is very true. You know, we start off with the basics, you know, reposition in the airway, using airway adjuncts as the OPA, NPA, oropharyngeal, nasopharyngeal airways. And then as we go to more advanced techniques, sometimes you just forget because you don't do it every day. And I would say, just like the AHA kind of fell back on, you know what, we need to focus on good CPR, good airway management. You know, don't worry about the intubation right now. Do good CPR, do good BVM or supraglottic airway. It's the same thing. Focus. You have to have good basics before you can go to more advanced techniques.
Yeah, absolutely. And they actually touch upon that in the next couple of steps too. Absolutely. So the second recommendation was EMS learners and clinicians must be educated in an escalating approach to airway management, where basic airway maneuvers form the central focus. So very similar to what Navin had just meant. And they tied this into actually specifically the psychomotor domain of the airway skills. So the cornerstone of all airway management encompasses a lot of things. One of those being your skill set. And having adequate oxygen and ventilation is how you have effective basic airway skills. And this actually is what makes a difference in patient outcomes, right? So fundamental procedural understanding can come from many aspects when you're trying to educate the psychomotor domain. That could be simulation, it could be supervised clinical exposure, all the way up to having real patients in a real life scenario. This one, they specifically had mentioned, has been the hardest one to ensure from a paramedic education standpoint, just because of different training centers and what they have access to. One study had highlighted that the average amount of intubations that a paramedic student graduated with was only seven intubations before they were graduating from whatever respective school they're coming from, which we can all gather that that's not enough to be able to be likely competent in this kind of skill. Navin, if you click next, I think another table should show up. Yeah, there we go. So this is one of their tables they had highlighted about different education tools for the psychomotor aspect of airway skills. And you can see that something as simple as task trainers all the way up to clinical field experience. They all have their strengths and weaknesses, but the goal is to always try to be lower on the list. And that kind of relies back on what resources you have and what you're able to access to be able to do this. Now, most of us are familiar with these task trainers and low fidelity mannequins and how we do most of our education and re-education as well. But they have a lot of drawbacks to it as well, since they're not high fidelity, they're not real life situations, and it's hard to apply your own critical thinking to these aspects when you have half a mannequin and you can watch the lungs expand, right? Because it's not realistic.
Also, I find that a lot of the low fidelity, they're much more difficult than in real life. I remember it was a long time ago, but my first intubation, I was like, that's it? That was so much easier than, I expected to have to like lift the entire body off the table with the laryngoscope. That's changed now with laryngeoscopy, but you know. Anyone have
Yeah.
any comments on what we've gone over so far? Anyone can chime in.
If not, you can click next, I believe.
All right.
All right, so these are the remaining recommendations for the first paper. So the third one is addressing the cognitive domain of education. So educational activities should extend beyond fundamental knowledge to focus on the development of clinical judgment. So on top of having those procedural skills, you also need to develop clinical judgment and execute higher order decision making. So this goes beyond the basic fundamentals, right? This goes beyond airway assessment. This goes beyond the physiology, the pharmacology, and you now need to tie that into clinical reasoning and having an endpoint to what you're doing. Many different aspects in relation to this kind of education. They pointed out things like recall, analyzing information, synthesizing, creating information, trying to tie that into an assessment skill. But the difficulty part is how you make that into an actual educational activity for EMS clinicians. And they touched upon a few things, one of them being an opportunity to reflect on decisions in context of clinical scenarios, trying to see if they can produce that situational awareness so that they can make safe decisions in high acuity environments later on. So this could also be in those simulation cases and you have them reflect on something. Or they talked about other strategies like the cognitive autopsy, think aloud approach. A lot of these are trying to get ways for them to be able to verbalize everything they're thinking of and making sure they're having the correct situational awareness when they're approaching airway competency. So the fourth one now is affective domain. And the recommendation here is optimizing patient outcomes should be valued over performance of an individual airway management skill. So this encompasses a clinician's values and motivation. And they're trying to move away from the older mindset that a definition of paramedic practice is intubation, intubation, intubation. Like that's what everyone prides themselves in. It's that intubation-centric education that they called it. And trying to move away from that approach because it really should be the right airway for the right patient at the right time. And that way you can actually value patient outcomes over procedural success. And that comes with having that affective domain, that comes with having professionalism, having empathy, and this is probably one of the harder things to also try to educate and teach because it comes from having role models, it comes from having your mentors and having intentional reflection on what you're doing. So this one was a little bit more difficult for them to have a direct recommendation of how to provide this kind of education, but it's also equally important because they're trying to move away from just intubating everyone in respiratory failure, right? Trying to optimize their physiology and choosing that right airway. So that was an interesting point for them to bring up. Fifth recommendation here talks about credentialing and continuing education, saying that the activities in airway management are essential and advance clinicians beyond entry-level competency. I think we all are very familiar with this. We all go through credentialing and continuing education. I like that they talked specifically about the role here for the medical director because we're the medical directors are the ones determining the ability for these EMS clinicians to practice, and we're verifying that they have the ability to be credentialed and go through that continuing education every year. But they highlight that it shouldn't just be that one-time event in the beginning, right? It should be a continuous process every year or every quarter. It's continuing education, continuing monitoring so that you can avoid skill deterioration because you can't control how much practice they get when it comes to airway management. And that includes, again, all the procedural skills and also that cognitive domain as well. 4 principles that they highlighted here specifically were making sure that you, as a medical director, can evaluate their cognitive knowledge, making sure you can evaluate their affective ability, the way they can display those psychomotor skills, and how they basically integrate all that together into decision making. And this kind of goes back to are you able to provide those high fidelity simulations or real life scenarios to give that education, to be able to give constructive feedback during that. The last recommendation talks about overall training and the evidence that's out there right now. So initial and continuing education programs should be responsive to advances in the evidence base and maintain adaptability to reassess content and expected outcomes on a continual basis. So this similarly ties into the last recommendation, basically saying that the initial focus is always going to be on the minimal competence, but that we should be moving and trying to push forward to more than just that initial minimum competence. It should be an overarching, safe and effective way that we can make decisions so that patient outcomes can be improved. And this can come from research, this is going to come from continuing education, this is going to come from everything that was highlighted in this document.
Yeah, a lot of what you're saying right now and all these different recommendations fall back into, get the minimum competency. So your initial education is, how do I make the intubation? Who needs intubation? Who doesn't? Later on, as you develop as a clinician, it's more differential diagnosis. Why is this person in respiratory distress? Is there something I can do that's better for the patient? Because intubation is not always the best thing for the patient. Could they benefit from BiPAP? Could they benefit from CPAP? Some places have high flow, or even other airway adjuncts that could help the patient, give them a chance to not get intubated.
Yeah, no, so they actually talk about later as well that a lot of that continuing education needs to be focused on the provider level too. So maybe for the EMT, it's working on the basic airway skills, and for the paramedic, it's being able to manage the EMT doing those airway skills, but then at the same time simultaneously thinking about, why is this person respiratory failure? But we frequently don't simulate that, right? We don't frequently have education specifically tailoring that specifically, and that's what they need to prevent that skill deterioration. So it's an interesting point.
I think, Jesse, some things you kind of mentioned, I'd like to just comment on. One thing I will say is that, basics, we talk about CPR and kind of going back to the basics. And I think the same thing is kind of with airway management. You really have to go back to the basics, and you have to kind of understand what your limitations are, and, and really kind of when to escalate levels of care. That cognitive ability, I think, is important to kind of think about, not so much for, obviously the cardiac arrest, obviously the obtunded patient, but really that the soft patient that's kind of borderline, and making that decision that this patient's airway is compromised, or, more so often is that there's an impending airway compromise that we need to intervene on now. Whether it's a trauma patient with expanding hematoma, whether it's the angioedema. I mean, those patients, we realize quickly that, those patients may need intervention, and having that forethought of, what's my expected management? How do I treat this patient initially? How can I resuscitate them? And then thinking about, now, what's my difficult airway pathway, or what's my airway management for this patient? I think that's huge. I think optimization, we kind of have moved, and made huge strides over the past several years regarding, resuscitative measures prior to, intubating, and, kind of optimizing blood pressure, SATs. And then kind of moving forward, I think, the dogma of making the tube on the first pass, it's just gone now, and we know that, really optimizing the airway, even if it takes a couple, looks for you to actually get an airway, as long as the patient doesn't desaturate, become hypoxic, become bradycardic, we know that we are actually, making better outcomes, versus if I had to get the airway on the first time and my patient becomes hypotensive or bradycardic or, hypoxic, or even arrests, those are correlated with worse outcomes in the first 24 hours of care. So, I think, optimization is key, and kind of looking at, forward thinking, how are we better optimizing our patients? How can we resuscitate them better before we intervene on their airway? And then thinking about some of those difficult challenges and how we escalate levels of care, kind of cognitively kind of planning the resuscitative efforts, and really kind of thinking in a stepwise fashion, when do you intervene and when do you not?
That's a great point. And a lot of that actually touches upon this next part for quality management too. If you want to go to the next slide, there we go. Yeah, so that actually is a perfect tie into the second paper, was quality management of pre-hospital airway programs. So we'll kind of jump in here. So quality management is the encompassing term for both quality assurance and quality improvement. So their first recommendation here is a little long, but all EMS agencies should dedicate sufficient resources to patient-centric, comprehensive pre-hospital airway quality management program. What does that consist of? It's prospective, retrospective, and concurrent activities, and should be developed and operated with the close involvement of the medical director. So their point they make here is that because of how complex airway management is and everything that Dr. Tagore just mentioned as well, it's a combination of a lot of things. It's having a robust quality management program. It's having careful and continuing monitoring of all the different things we just talked about in the first paper. Quality assurance specifically is measuring how well we are compliant, right, with different standards, and then quality improvement is taking those systems and seeing if we have a process to identify and act on, whether it be errors or anything that's measurable to improve certain opportunities. And the important part of that recommendation is that traditionally we're used to having a retrospective review of quality management. It can't just be retrospective to detect these deviations. It needs to be things that are going on currently, and then it needs to be finding ways to challenge yourself to have prospective thinking as well. And this starts with just individual cases, but challenges of these individual cases can easily point to larger systemic issues, and that's what we can use for recommendations for training. In terms of what the medical director role is, it's ensuring that the overarching program that you implement is tied into medical evidence that supports best practice, and it's aligned with goals of actually improving care. And that's what they mean by their patient-centric that they use, improving patient care. The approach on all these elements can be a lot of different things that you can measure. It could be focusing on avoidance of hypoxia. It could be avoidance of hypotension, or something that was mentioned earlier of improving first pass success. And one of the things that they had talked about for quality management as an example is like an airway checklist. Is that some way, if you have a single case or systemic issue of peri-intubation hypoxia, is having a checklist a good way to try to prevent that. And that kind of ties into, again, having that retrospective knowledge of what has happened, concurrently going through the data of what's happening right now, and then trying to prospectively think of how to fix that and to address it while also still monitoring the things that are happening. One of the process for making this a concurrent process is this kind of chart here that a lot of you guys might be familiar with, the Plan, Do, Study, Act cycle there, talking about how any effective process should be cyclical. It's not just one single event. This allows it to be continuous movement towards that goal that you may have. And this comes from the Institute for Healthcare Improvement model. All right. Go to the next slide here. All right, so number 2, quality improvement and quality assurance efforts should operate in an educational, non-disciplinary, non-punitive, evidence-based medicine culture focused on patient safety. And the highest quality of care is only achieved when the quality management program rewards those who identify and seek to prevent errors before they occur. I think this is pretty self-explanatory in that we have a traditional perception that anytime we get a QA on our flag or we get QA'd on our charts, it means that there's something negative about to happen or something punitive is about to happen. And that really just causes lower morality, causes lack of engagement, and that's exact opposite of what we want, right, from quality management. So the focus should be on education, focus on system enhancement, not individually blaming one person. And a lot of that ties into just culture and culture of safety. And I know there are a lot of lectures on it and the different EMS conferences that have just happened. But that really does allow engagement from both the medical oversight and the operational system leadership if you are able to implement that kind of mindset instead of that punitive and negative approach.
Yeah, you shouldn't get palpitations when you get that QA flag. Hopefully it's like, oh, there's something on this. And this is why, like, I promoted a bunch that, QA flag should also be used for, like, hey, this was great documentation. Hey, this was a great management of this case. And then also, I know that it happens also on the workplace where it's just like, hey, there was this great case, It was managed great by the team, and thank you for what you do. And that just culture where treat near misses even more than actual when something goes wrong, because a near miss is something that should trigger, be like, hey, we got lucky. Let's make sure that we don't get lucky next time, and that this is just taken care of. It's that Swiss cheese model.
All right. So the third recommendation here, efforts have been made, information evaluated in pre-hospital airway quality management programs should include both subjective and objective data elements with uniform reporting and operational definitions. So actually, if you could click one more time for me, Navi, I think a chart's going to show up. There we go. So a lot of ways to try to tie in uniformity when it comes to key data points, and it's something that I think we still struggle with as basically society and EMS reporting. And so a while back, they talked about how they're trying to implement this Utstein style uniformity, and it really comes from the cardiac arrest data that we used to have. And they're trying to be able to find ways to evaluate these pre-hospital airway qualities, whether it's the case demographics, pre-intubation, peri-intubation, or post-intubation data, and what kind of outcome metrics you're using for quality management. So this table 1 here shows a little bit of each of these examples, and each of these examples is what can drive questions about how you approach quality management. It's finding that source of your data, and then making sure you also establish definitions of each of these metrics so that you can limit any kind of bias that you may have. An easy example is, what do you constitute as an airway attempt, right? Is it when you're opening up the airway? Is it when you stick a laryngoscope blade in? Is it as soon as you make contact with the teeth? It's making sure you have those preset definitions so that when you do look at each of these data points, it's more uniform and the reporting actually means something. And the biggest barrier for this is that even though we have more and more available data from all of our monitoring capabilities and recordings, it's still not universal. One EMS agency to the next has different technology, different budgets, different ways that they're keeping track of everything. So it's the one thing that has been pretty variable and makes it hard for us to be able to have uniform data on all these things. But at least from a system perspective, more local perspective, these are all different components that we should be taking a look at to allow for better quality management. All right, next slide. All right, so fourth recommendation here, EMS systems should regularly measure and report process, outcome, and balancing airway management measures. So measurement ends up being very important, right? To see if changes that we implemented led to some sort of desired improvement that we had. And they talk about 3 different types. There's outcome measurements, process measurements, and balancing measurements. Outcome 1 is probably something that we're very familiar with. It's, what is that endpoint? What kind of action did we make to be able to cause that patient-centered outcome? And it's hard to tie what we do to these outcomes, though, because a lot of times it's not direct, it's not correlated. So what we really should be focusing on is the process measurement. And that's the adherence to the evidence-based protocol or practice or whatever kind of guideline that we may have for our agency. And that's how we can really capture and measure things that are happening or errors that are happening, if we can take a look at what that process is. The last one, the balancing measurement, is measuring unintended consequences when we're trying to improve things. And an example that they used was, if the system has some sort of trouble with first pass intubation rate, and you want to make sure that when you're trying to fix that, you're not also unintentionally causing an increase in first attempt peri-intubation hypoxia. So it's a good thing to think about, because everything that you implement can always have something that backfires or some sort of adverse outcome tied to it as well. So overall, with using these 3 different measurements, that's how we should be viewing our data and helping us separate things that are randomly occurring versus not randomly occurring. The 5th recommendation here, quality management activities require large-scale bidirectional information sharing between EMS agencies and receiving facilities. Hospital outcome information should be shared with agencies that involve EMS clinicians. I think this is something that we all are pretty aware of and wish that this was happening everywhere and quicker. So it's not a new information for us. And this is beneficial because that allows the hospital to review what we did as pre-hospital providers, And then it allows pre-hospital providers to look at what patient outcomes were, what are their treatments, and if it was really truly tied together, you can even see the history en route to a hospital that can guide that clinical decision making we talked about in the last paper. And again, of course, this is not a common practice yet. This was touched upon in the EMS agenda for the future, 2050. So obviously that's very, very far away, but it's a goal, and it's something that we're increasingly trying to talk about to be able to implement that system together. And I know we're implementing that a little bit more and more now with our systems here. The biggest thing that they were able to see from COVID was that because of how important clinician safety was and knowing if we were exposed or not when performing aerosolizing procedures, having that bidirectional data sharing can also improve a lot of both outcomes and just awareness level for EMS clinicians. All right, so last two recommendations here. So the sixth one, vital our findings from quality management programs should be used to guide and develop initial education and continuing training. So basically saying that everything that we learned from in the last few steps, we should be using to educate our providers and providing that system knowledge. So airway management is, again, that core, right, for both basic and advanced pre-hospital clinicians, no matter what level you're at. So every educational intervention that we make, whether it's a didactic, whether it's skill, should be based on quality improvement efforts. And going back to that prospective tool, you want to be able to prospectively monitor airway skills, their outcomes, and then that's how you identify areas for improvement. The procedural rate variation between individual clinicians, right? So there's kind of this broad systemic and way to be able to educate everyone, but then if you are able to, the more ideal QI effort would be also providing that personalized education programming. So that could be what we talked about earlier with tailoring simulations to the level of the provider or the level of error or misconception that might be happening that requires education. And you can get that information by having those quality management tools in place so that you can find what's working, what's not working, things that are happening retrospectively and concurrently. A good example of this is if you're having high frequency of your ET tube being dislodged, and you want to be able to introduce some sort of new airway device or new airway technique that kind of ties into every level of care, and then trying to see whether or not retrospectively and prospectively you're able to fix that. Last recommendation here, quality improvement programs should continually undergo evaluations and assessment to identify strengths and shortcomings with focus on continuous improvement. Again, similar to evaluating and setting goals for airway processes, we also need to regularly evaluate our airway quality management programs, making sure that we're not having huge performance gaps, making sure that we are addressing those gaps, and that we develop goals and these design measures to tailor airway needs. Kind of just summarizes basically all of the recommendations in the past together.
Yeah, one of the things that didn't really come out with the position statements and everything was that this information is actually bidirectional too. That you're also getting feedback from the clinicians on the ground who are doing the intubations with the laryngoscope in their hand, that can report up those chain and say, hey, for some reason we got different handles this month, and you know, instead of finding out the next month that why did our first pass success rate drop this month, you can kind of head it off ahead of time, maybe put out new education. A lot of times for supply chain issues, which unfortunately we've been seeing more of lately, you know, people will just swap things in without even letting anyone know. And that's from a logistics standpoint. I know that like I've received drugs that are like, wait a minute, this isn't what I'm usually getting. So you have to do a double take. You have to take a star moment and like look at your drug and the dosages and everything, just double checking that everything is correct. Same thing with this, where you know you're being able, using that just culture to reply and say like, hey, I've been having problems with intubation because like for some reason the tubes are different. You know, maybe it's the stylet that's different, and then being able to kind of troubleshoot that ahead of time. And every system's different. Some system, maybe every single medic gets one intubation a month. Some other places, they get one intubation a year. So either having more live training for those people who only get it once a year, and then more advanced training for the people who are intubated monthly or even weekly.
Yeah, and that goes into saying the whole unreliable factor that, you know, a lot of clinicians are misconceptions that you can just rely on clinical experience, but it's unreliable in terms of frequency, in terms of what you may be doing, and what you may be doing may actually even be correct. So yeah, there's a lot of little points there that tie in together. So the final paper that I'll be covering here is pre-hospital manual ventilation and its recommendations. So the first two are here. First one, all EMS clinicians must be proficient in bag valve mask ventilation. So I think we can go without saying bag valve ventilation is probably one of the most critical skills that we are competent in. And manual ventilation, essentially using some sort of self-inflating bag device, and it could be attached to a face mask or some sort of invasive airway. And so we're traditionally using bag valve mask or bag valve devices. And it's a really truly fundamental resuscitation skill. It's adjunctive role for initial stabilization, for pre-oxygenation, for reoxygenating as well. So definitely very important. This specific section actually touches on quite a few research papers that have come out, and all of them with different kinds of statistics. One of them being that intubation failures in some EMS systems are as high as 44% still. So that's kind of scary, right? Because this is, again, what we said, this is our fundamental skill that we are starting patient resuscitation with. And we're saying 44% are still not able to do this, or have 44% cannot intubate correctly, then we're going back to bag valve mask. So it just highlights how important that skill is. We consider it a basic skill, but it's still challenging. Another study pointed out up to 15% of clinicians still have difficulty in adequately using a bag valve mask. And a lot of different components go into this. This could be environmental challenges because we're always in different environments. They also highlighted older age, higher BMI, lack of teeth, facial hair, history of snoring. All of that makes for difficult airways and difficult to be able to bag valve mask. And then that competency that we want to be able to address, that say that we're actually proficient, encompasses a couple things. Encompasses the mask seal, encompasses having a patent airway, and encompasses being able to deliver at good ventilation. And at the same time as all that, you're trying to mitigate and prevent hyperventilation. You're trying to prevent insufflation of the stomach, right? So that you don't cause aspiration. And all that tied together is what allows us to be proficient so that we can increase success with that advanced airway and actually optimize that airway management. And I really like that they keep using the term airway management because it's not one specific tool that we're using, it's all these tools together that allows for patient outcomes. Second statement here, recommendation, BVM ventilation should be performed using a two-person technique whenever feasible. So obviously, whenever feasible is that caveat there because a lot of times it isn't feasible. But specifically talking about the two-person technique, they highlight over and over again that two-hand mask seal that we have, and that hold is increasingly better than having just one provider doing it. So that actually allows the bag to insufflate, and we actually increase mean tidal volume for the patients. One of the studies they highlighted here was that over half of EMS clinicians were not able to provide effective ventilations when operating a BVM alone. And actually the amount of tidal volume and proficient bag valve mask that they did was still worse than having a two-hand grip with pocket mask, or sorry, two-hand grip using a pocket mask outperformed using a BVM with a one-handed mask seal. So it just goes to show that this is still a difficult skill to be able to be proficient at, and we're still not doing a great job at it sometimes. Another study they looked at was similarly comparing mouth to mouth, and that tidal volume for over half the people using a one-handed bag valve mask was still lower quality than those using mouth to mouth and mouth to mask. So just kind of a way to be able to keep things in perspective when we are thinking about BVM, and that, again, even though it's a basic skill, it can still be challenging.
I mean, I can tell you from my experience that, you know, bag mouth mask ventilation seems simple, but it's completely not. You know, whether or not you use like an airway adjuncts can sometimes help, or also, you know, doing the EC technique, the one-handed EC technique, trying to lift that jaw up. you get a cramp in your hand because you're not used to using that muscle. And then even I've done it. I've caught myself doing it where I'm shoving the mask on the person's face to try and get a good seal while blocking their airway with their tongue because I'm not lifting their jaw up. One of the things that is also important, going back to that teamwork approach, and this comes from a lot of the helicopter stuff, is cross-check. You cross-check your partner. I just finished the IV and my partner's bagging the patient, and it's like, I don't think you're bagging very well. Can you lift up the jaw a little bit more? And having that not be, an insult to them. That'd be like, oh, thank you for letting me know that, and taking care of that patient.
Yeah, absolutely. An idea that I thought they brought up that was kind of interesting was one agency had done a quality management report on one of their cardiac arrest simulations where to try to improve CPR quality and ventilations, they had one person using the two-handed mask seal approach, and then after the person finished 30 compressions, they're the ones that would squeeze the bag. And their little study that it was still able to maintain good CPR quality, and then at the same time improving ventilation quality. And obviously would take some simulation and some education to be able to coordinate that, but it was an interesting idea that they brought up. If we go to the next slide. So this is our last recommendation here. EMS clinicians should use available techniques and adjuncts to achieve optimal mask seal, improve airway patency, optimize delivery of the correct rate, tidal volume, and pressure during manual ventilation, and continual assessment of manual ventilation effectiveness. So very long thing to essentially say we need to focus on each of these components that goes into manual ventilation to be able to actually provide good airway management. So the techniques to improve manual ventilation, it's shown here to the picture on the left there, all those different adjuncts that we can use. And the right picture here is different ways for mask seal. So we're going to talk about that first. So for the mask seal, we talked about how the two-hand is supposed to be more superior. However, obviously, if it's not feasible, then you're back to a one-hand version. So EC configuration, similar to what Navin had just mentioned, is what we're used to the most. They also bring up in, I think, picture D there, so the thenar eminence grip. Some studies that they highlighted was shown that this was superior when they were first teaching new providers this technique, and it was better for those with smaller hands. So that's another way to be able to do that. So basically, both of your thenar eminence is on the outside of the mask, and then the rest of your fingers are underneath the mandible there to provide that lift. And then the other grip that they also have you can see in picture B there, is they're calling it the EC configuration, or EC grip. EO grip. You're essentially making the O around that neck of the mask. And one of their randomized blinded crossover study in the OR, so again, not ideal since it's not accurately portraying our environment, but at least in the OR, they found that this provided better seal and better ventilations that they were providing. Other barriers with the mask that we talked about earlier was those with dentures and those with beards. With dentures, they actually advised keeping them in place to provide a little bit more structure so they could actually provide those ventilations. And they actually had one innovation study that placed gauze in the buccal space, and it actually improved ventilations as well. So I thought that was interesting. And then for beards, one of their education models was actually using gel on the mask, and supposedly that actually improved tidal volume by over half. It went from around the upper 200s to mid 400s in tidal volume because it provided that more accurate seal, so you don't have that air leak around the facial hair. The other component they talked about here, so improving airway patency. So that's essentially positioning your head and neck so that you don't have collapse of your soft tissue structures, whether that's the soft palate, your tongue, that could be causing obstruction. We traditionally have learned about the sniffing position, so we're aligning those the mouth, larynx, and pharynx axis together. And other components of that, though, is also whether you're displacing the mandible or the hyoid to be a little bit more anterior, or you're elevating the occiput so that the airways look more patent that way. their adjuncts that we have in that picture there, whether it's the OPA or MPA. It's something that's probably undervalued and not talked about enough. That gets highlighted, that the positioning and sizing is actually incredibly important. Multiple studies, most of them being out of Japan. Obviously, if it's too small, it does nothing. And if it's too large, and that can actually displace the epiglottis, so that it actually paradoxically causes airway obstruction. So again, both outcomes are not ideal. And they had one study that tried to find the best way to size the OPAs, and they placed a fiber optic bronch in the OR down these patients as they're doing this. Obviously, we can't do that in our setting right now, but they were able to at least find that the best positioning is for the airway to just barely be touching the epiglottis, not fully touching it, but not too far away, but it's just be barely touching the epiglottis is that ideal location for OPA. So how we measure that, I don't think we know 100% yet, but they're trying to find ways for us to find better ways to size these airway adjuncts.
Yeah, the OPAs and the MPAs are probably the most underutilized airway tool in our arsenal. I see it all the time where people are bagging without these in, even ALS providers where, you know, they tried to intubate and they couldn't, and there's still no OPA or MPA. And then one of the things that I found with intubation, you know, people tell me, oh, there was a foreign body. I couldn't figure out what it was, and it was because someone put it in an OPA or NPA, and they're just not used to seeing it.
Yeah. So last point here that I'm going to make. So the rate and volume that they talk about, and something that has become more frequently brought up is the tidal volume we're giving these patients, and traditionally it's too much. So AHA recommends 10 breaths, tidal volume between 500 to 600. For peds, it's 20 to 30 breaths, and they don't actually have a recommended tidal volume, but we frequently hear anywhere between 6 to 7 cc's per kilo. And the goal of this is just to make awareness that we need to avoid excessive ventilation. There's so many studies that show that we're really giving too much tidal volume to these resuscitations, and one of them actually said that there was rates going as high as 50, and we're frequently distracted when we're ventilating and not realizing how much we're giving. And only 42.3% of clinicians were able to deliver the targeted tidal volume correctly, which is a little frightening to think about, that it's actually causing a lot of harm, right, to the patients. When you give too much tidal volume, you're increasing that intrathoracic pressure, and that can do a lot of things. It could decrease blood flow, it decreases coronary perfusion pressure, it causes barotrauma, and then aspiration. So you're increasing that morbidity and mortality exponentially when you do that. Some of the fixes that they suggested, timing and feedback devices. So that could be like metronomes and cadence and feedback devices. Again, that's more resources and things that an agency needs to look into or invest in, but these are ways to improve patient outcomes. Another one was changing bag sizes. So a lot of things I know some agencies are doing is using pediatric BVMs, because those tidal volumes are still between 450 to 650, which is more than enough for adults, and actually allows more consistent tidal volume to be delivered, and better technique that can be done because you're not trying to wrap your fingers around an adult size BVM. So just a lot of things to think about. And then in terms of ventilation quality, a lot of that goes back to using capnography, and I think we all know that's the gold standard to actually use that depicted amplitude as a surrogate for our exhaled tidal volume, and that allows us to try to measure anything from ventilation to how well perfusion is happening, but they just highlight that it's important to do. And then overall, their theme is, what's that?
Oh, specifically waveform capnography, not colorimetric.
Yeah, specifically waveform capnography. And lastly, just that there needs to be more future research. So we need more strategies to actually confirm quality of manual ventilation so that we can actually directly train or figure out how we can attain and maintain competency for ventilation, because a lot of these studies are based on the OR or in simulations and not actually in the diverse environment that we are frequently encountering. So still lots of research needs to be done.
Yeah, I just wanted to say that the picture doesn't have a PEEP valve.
Oh.
But for those of you, the PEEP valve, you would just replace, if you look at the EC method right above the C, you pop that cap off and you put the PEEP valve right there if you have a third-party PEEP valve. All right, Chowdhury.
Hey, good morning, guys, or good afternoon. So today we'll talk about the next topic, which is the NAEMSP position statement on pre-hospital supraglottic airway devices. Navin, if you want, you can go back to like what you were doing originally, which was if you wanted to, like the website, and then you could just follow along through there. Basically, supraglottic devices are advanced airway devices intended to be inserted into the oropharynx without laryngoscopy. It provides an indirect oxygen delivery to the trachea and it provides ventilation. It may also offer protection from gastric aspiration. We'll get into that a little bit later, since there is this idea that maybe it may worsen gastric aspiration, or at least there's this thought behind it, and that's why people are a little bit hesitant to do supraglottic airways. Traditionally, EMS providers use supraglottic airways as a rescue device after failed intubation. Now, supraglottic devices are being used as a primary device depending on the clinical scenario. And there have been recent developments in supraglottic airway education, science, technology, and all of these have influenced our use of supraglottic devices. So as I mentioned earlier, there was a shift of supraglottic airway devices from rescue to now using it as even a primary device. The reason why is because I'm sure we've all experienced it or seen it. We now have this iGel device. It's newer. It's functionally superior to other devices, and it's been shown more recently that there have been an increased recognition of failed endotracheal intubation, and there are pitfalls with immediately jumping to endotracheal intubations in the EMS setting. And given the clinical scenario, supraglottic airways would have been considered the optimal route. There are several trials demonstrating better outcomes and faster processes of care with supraglottic airway over endotracheal intubation. In this position statement, they pretty much are emphasizing that supraglottic airway devices must be a part of our airway management system. It should be protocolized and integrated with our endotracheal intubation strategies. We must plan for a failed intubation every time we plan to intubate, and those failed intubation strategies could include BVM and supraglottic airways. It should be a part of the pre-intubation briefing that these devices are here and available, and we'll go to them as a secondary strategy if intubation fails. But like I mentioned earlier, it doesn't always need to be a secondary strategy. It could be a primary in certain scenarios. And ALS ambulances should be stocked ideally with supraglottic airway devices ranging from neonates to adults. I'll get into this a little bit more into the next NAEMSP position statement, but DAM, it's called it stands for, so it's DAAM, it stands for Drug Assisted Airway Management. It's another word of essentially saying RSI or RSA. RSI meaning rapid sequence intubation. We're not talking about intubation here, but RSA, rapid sequence airway. There is a role for basically medications, utility in patients who will be getting a supraglottic airway. Those medications are the same as we would use in RSI, so sedatives and paralytics. Obviously, we would only consider using them in certain scenarios. Recent large case series have shown success rates in using DAM with supraglottic airways as high as 94% success rates. And the aspiration rate was equivalent to other methods of airway management. It's been shown that the ease and speed of supraglottic airway insertion versus endotracheal intubation has shown to reduce rates of hypoxemia and airway trauma. Another reason to consider supraglottic airway over endotracheal intubation. But obviously, with any medical intervention, there are disadvantages to supraglottic airways. One would be if a patient would require high airway pressures, that likely would not be achieved by supraglottic airway insertion. If there's an inability to access the airway reliably to suction, if the patient needs to suction, sometimes supraglottic airway is not always appropriate. There is this perception that supraglottic airways are unable to protect against aspiration. Like the iGel and other devices now, there are new supraglottic airway devices that have aspiration lumens to allow for the evacuation of gastric contents. So that perception is not necessarily true now with the newer technology. And there's also this perception that supraglottic airways are going to be replaced anyways in the hospital for an endotracheal, for an ET tube, so why not just perform it pre-hospitally? And while that's true, again, if the patient doesn't necessarily need it emergently pre-hospitally, technically in the ER, it's a more controlled setting, and so it may be better just to get that supraglottic airway, and that conversion will occur in the ER in a more safe and well-staffed setting. So how do we confirm supraglottic airways if we do get them? The simple ways, which include auscultation of breath sounds, visualization of chest rise, visualization of condensation in the lumen of the supraglottic airway, but they emphasize, as we were talking about earlier, the importance of capnography. Waveform continuous capnography is the most reliable, and we'll talk about that a little more afterwards. Should we ever convert a supraglottic airway to an endotracheal intubate, to an ET tube pre-hospitally? The answer is generally no, especially if the supraglottic airway is successful. Now, are there reasons to convert it pre-hospitally? The answer is yes, and that's only if, again, if the patient needs high ventilation pressures, if there's deep tracheal suctioning that needs to be performed, and you cannot really perform that with a supraglottic airway. If there are copious secretions, bleeding, emesis, and you truly are concerned about aspiration, then converting it to an ET tube would be considered. And if there's significant amount of infraglottic swelling, such as in angioedema and anaphylaxis, where you're unable to adequately ventilate the patient with a supraglottic device. So how do we train our providers to be competent with supraglottic airways? As this is a procedure that's generally considered to be low frequency and high risk, and so it should be subject to the same rigorous quality management practices as endotracheal intubation. Clinicians should be periodically assessed for their cognitive, psychomotor, and affective competencies, kind of like what Jesse was talking about. And medical directors should understand how supraglottic airways, just like endotracheal intubations, can impact clinical outcomes. And so finally, the general NAEMSP recommendation for supraglottic airway devices is they have utility as a primary or secondary EMS airway intervention. EMS agencies should select supraglottic airway strategies that best suit available resources and local clinician skill set. And EMS agencies that perform endotracheal intubation must also equip their clinicians with supraglottic airway devices and ensure adequate training and competencies with those supraglottic airway devices. Any questions in regards to this position statement, or should I move on to the next one, which is specifically about DAM, the drug-assisted airway management system? All right, so I'll move on. So DAM, like I had mentioned earlier, it's another way of describing RSI versus RSA, rapid sequence intubation or rapid sequence airway. Airway management in general is a critical intervention for patients with airway compromise, respiratory failure, and cardiac arrest. The methods by which airway is managed is influenced by the presence of airway reflexes and the need to preserve their hemodynamic condition. So DAM is a technique used, it's a technique in which we incorporate medications before we decide to rescue a patient's airway. And so we administer sedatives and paralytics. And while DAM provides several benefits, including improved laryngoscopy for successful insertion of an ET tube or supraglottic device, DAM also carries very important risks. And so that's why there's so much training and quality management to ensure that the procedure is done safely and effectively. In general, there are ongoing controversies surrounding DAM. Like, what are the necessary components for training and credentialing providers? What is the optimal approach to pre-oxygenate before you administer medications? What medications would be best suitable for a particular patient? Let's say if a patient is unstable, what medications would you consider in terms of sedatives and paralytics? How do we confirm the airway once we have successfully acquired it? And what are the essential components of quality management to ensure that, again, your DAM practice is performed safely and effectively? So DAM, it's an appropriate tool for EMS clinicians in systems where there are clear guidelines, sufficient training, and close EMS physician oversight. DAM should not be used in settings with inadequate resources. Specifically, EMS medical directors must ensure commitment from the entire agency leadership to support an increased budget for proper equipment, training, and oversight. Medical directors must select appropriate drugs and equipment and develop protocols, training, credentialing, and quality management practices that address all aspects of the DAM process. So what are the risks with DAM? Well, studies have shown peri-intubation cardiac arrests occur in 1 to 4% of all RSIs. And this highlights the importance of physiologic monitoring and management that are critical to all aspects of DAM. Airway management using DAM requires, going back to what Jesse was discussing, it requires psychomotor skills, knowledge, and critical thinking. And so what should DAM programs include before they're initiated? As I mentioned, they should include protocols and procedures that highlight the following. I'm going to kind of list these out. They're patient assessment, patient selection, which patient would be a good candidate for DAM, positioning the patient before you decide to perform this intervention. What type of pre-oxygenation are you going to provide to a patient who is breathing but maybe have a low respiratory rate? What type of oxygen are you going to give to an apneic patient? What monitoring and management devices what monitoring are you doing in a patient who you do anticipate that will require this airway? What medication are you going to select for this patient? What equipment are you going to use? What post-intubation analgesia and sedation are you going to provide? What post-intubation confirmation and monitoring device are you going to utilize? What are your rescue airway techniques? Are you going to continue to use the BVM or supraglottic airway, or are you going to need to do a surgical airway? And what alternatives to rapid sequence intubation or DAM does your institution support? Is there sedation-assisted intubation, meaning maybe sedate them a little bit, have them continue to breathe, and then decide to paralyze and intubate them so you could pre-oxygenate them? Is there delayed sequence intubation, which is very similar to sedation-assisted intubation? What are the scenarios where those alternatives to RSI would be optimal? How do we perform once you've created a DAM system? How do you perform quality management of this? Well, each DAM case should be reviewed. There ideally, if possible, be live in-field observation and debriefings. If not that, then maybe longitudinal efforts to identify opportunities for performance improvements. Periodic assessments of these cognitive, psychomotor, and affective skills. Measurement of metrics, and the reason why, and the most common metric that we hear of is first pass success rate, but like Jesse was saying, that is not the only metric that we should focus on. Don't forget about other metrics that can affect a patient's final outcomes, such as peri-intubation hypoxia, hypotension, what agents were used, why. So in summary, the NAEMSP recommendation of DAM is that DAM is an appropriate tool to use for EMS clinicians and systems only where there are clear guidelines, adequate equipment, training, credentialing, and close EMS physician oversight to ensure appropriate patient selection, patient optimization, and quality management. And DAM should not be used in settings without these adequate resources or methods to monitor and ensure patient safety. Are there any questions in regards to the DAM position statement?
I mean, I think they made a new term to kind of encompass all of what we do with, it's not just RSI or delayed sequence intubation, it's drug assisted airway management, and just a more broader term for what we've been doing.
Yep. I thought it was an interesting term.
And also, it's important to mention that even though you say rapid sequence intubation, it's never rapid. So I think the drug-assisted medical management, it makes more sense.
And sorry, guys, I just realized my camera, I am completely dark. I probably should not be sitting back here.
I was going to say, you look like you're in witness protection.
Yeah. Yeah, actually, I thought I was in a bright place, but I guess not. I'm sorry, guys. So I'll move on to the final EMS position statement that I'll be going over, and it's the pre-hospital drug-assisted airway. Sorry, it is the
Hospital cardiac arrest airway management.
Yeah, yep, exactly. So pre-hospital cardiac arrest airway management. So airway management is critical to treating out of hospital cardiac arrest. Multiple techniques are available, including bag valve mask ventilation, supraglottic airway insertion, and endotracheal intubation. But the goal is to achieve optimal oxygenation and ventilation while minimizing interference with other resuscitative interventions during cardiac arrest that have been proven to improve survival. So which airway method is best? The answer is we don't know. Selection of the type of airway management strategy depends really on the arrest circumstances, patient factors, what stage in the resuscitation you're in, what available equipment you have, what's the skill level of the practitioner, etc. There's no randomized controlled trial to compare all three, and there's limited data to show patient-centered outcome differences between BVM, supraglottic airway, and intratracheal intubation in a patient that's in cardiac arrest. And so obviously this means that there's further more robust and controlled design research is needed to delineate whether there's a survival advantage to one particular airway device. Like I had mentioned earlier, the goal in airway management is to minimize interference in resuscitating the patient. So what should we prioritize in a patient that is in cardiac arrest? It's high quality chest compressions, it's rapid defibrillation, and it's addressing all reversible causes. If the patient needs BVM, if their airway does need to be secured, again, consider the clinical scenario and when you want to initiate that. They did mention that there were some studies to show that maybe if you immediately arrive to scene, consider first 3 cycles of CPR and rhythm checks before intratracheal intubation. Consider maybe passive oxygenation via nasal cannula and face mask before other devices you decide to take the airway in other ways. So it's not always immediately jump to securing the airway. It's first consider the high quality chest compression, the rapid defibrillation, and addressing reversible causes. The AHA recommends,
some people have misinterpreted those statements, and I mean, I'm in the belief that you don't have to jump to intubation right away. you can use an airway adjunct such as an OPA or an NPA, and also your bag valve mask to deliver oxygen and ventilate the patient. Some people, you know, they jump straight for intubation. That's the way I was taught when I was a paramedic. It was just like secure that airway first. Forget everything else, you know, forget circulating blood and, you know, oxygenating the brain. But that shift makes sense. You know, the advanced techniques don't help unless you have the basics taken care of.
Yeah,
And
so
the whole idea about minimizing interference with other resuscitation priorities, this is actually very specific for EMS because we are a resource poor area, not necessarily even with all the money or resources you have. If you show up on scene as a sole paramedic or a two paramedic unit with some BLS, that's it. That's all you have to work with. So, you know, what's more important? Do you want to start establishing your line, getting the CPR going? You know, we went through that whole time when we were doing pit crew CPR. You know, get that CPR going, good quality CPR. You know, ventilate the patient, get an IV. You know, address your H's and T's. You know, is the endotracheal tube going to change that? You know, with proper oxygenation, with a OPA and a BVM, it's not. So, you know, you push that down your priorities because your airway, although not quote unquote secure, you still have a good airway.
yeah,
And you're no longer in witness protection.
yeah, I thought it might help. So the AHA generally recommends, you know, maybe when in regards to administering supplemental breaths, 2 breaths every 30 seconds or 1 breath every 6 seconds. If you are going to give a breath administered over 1 second, and generally for adult patients, consider administering 500 to 600 cc's of tidal volume breaths. Again, there's no evidence behind this, but what there is evidence behind is that hyperventilating patient does cause harm. The physiologic reason for it is when you hyperventilate someone, you induce air trapping, there's reduced exhalation, there's an increased intrathoracic pressure now, you've decreased venous return, and now you've decreased cardiac output, decreasing their likelihood of now achieving ROSC. So what can we do to ensure or to avoid hyperventilation? Kind of, again, what Jesse had talked about, maybe there's some metronomes, timing lights, ventilation feedback devices that are now being made. And going back to what I had discussed a little bit earlier in regards to capnography, there's a big push towards ensuring that, you know, end-tidal CO2, it's very important to have that device on, especially in a cardiac arrest, especially if you're providing or administering or starting some type of oxygen like an endotracheal tube or supraglottic airway, to see what that end-tidal CO2 is. And the reason is multifactorial. End-tidal CO2 is influenced by multiple factors, and an EMS provider must know how to interpret that end-tidal CO2 and what it means. In general, capnography, it monitors the flow of carbon dioxide through the airway. It measures the ventilatory status or the alveolar gas exchange at the lungs, but it correlates with cardiac output. It indicates what pulmonary and cerebral perfusion the patient has. End-tidal CO2 essentially can help guide resuscitation. It helps us know if the advanced airway that we placed is positioned correctly. It helps us understand if the ventilation we're providing and the compressions we're administering are effective. And it also tells us if the patient has obtained ROSC or has a rearrested. So some general pearls that they had mentioned was, you know, targeting the end-tidal CO2 to ideally above 20 millimeters of mercury tells us that maybe, you know, you are providing effective and adequate CPR. A sudden rise in end-tidal CO2 to 10 or more millimeters of mercury is suggestive of ROSC. And in the absence of an endotracheal tube or supraglottic airway that's maybe dislodged or obstructed, an end-tidal CO2 of less than 10 persistently for more than 20 minutes of CPR, there's an estimated less than 0.5% chance of achieving ROSC. And so maybe that suggests a futility in resuming ROSC or in resuming resuscitation. But ultimately, more research is needed to define the potential of capnography in cardiac arrest. But in general, the final EMS position statement on cardiac arrest airway management is that all devices, BVM, supraglottic airway, and intratracheal intubation may be considered in airway management. It just depends at what stage in the resuscitation are you in, what is the clinical scenario, and if there is a utility for it. Airway management should not interfere with the other key components of resuscitation. Again, chest compression, rapid defibrillation, and treatment of reversible causes. You want to avoid hyperventilating, and capnography will continue to play a role in cardiac arrests, especially in airway management, in terms of guiding ventilation and compression, confirming our advanced airway, and assisting in our decision whether to continue to resuscitate or to terminate.
And we all know that 10 years ago, you'd always hear it, stop chest compression so I can intubate. And we hear it less now, but we still hear it, where it's like, we know that we're doing harm by doing that. So either intubate through the chest compressions or just drop a OPA or supraglottic, get ROS, and then do your intubation.
Question: how many of you still use end-tidal CO2 as a determinant to stop resuscitation?
The waveform or like the volumetric or?
No, the waveform.
So during CPR or like as you just show up on scene and?
During CPR, because I've had like multiple encounters where patients being resuscitated for an hour and the provider wouldn't stop resuscitation because the end-tidal is like 70, even though it's been an hour. They haven't gotten ROS once.
But the end-tidal is 70.
Yes.
70. So the thing with that is that the 70 is telling us that you're doing really good CPR. But the problem is that the evidence that we have right now, and mind you, the evidence is fairly new. Cardiac research isn't that great, and we haven't had this data in the past. What we know from the literature is that any resuscitation over 20 minutes, you probably have some sort of hypoxic brain injury. They're the 5 things that show good and bad outcome. One of them is initial rhythm. The fact that you have no changes for an hour, very bad outcomes. The fact that it's been over 20 minutes that you've been doing CPR, bad outcomes. And even with the end-tidal CO2 of 70, that's the time where you kind of have to decide, like, either transport to the hospital or pronounce at that point, because with no change, if in that hour of resuscitation, I had EKG changes, basically every single time there's a change, the clock resets, at least in my view.
One of the things that you kind of have to look into is when you're utilizing end-tidal as a surrogate marker, obviously we're looking at that as a surrogate marker of perfusion. Other things people look at are like cerebral perfusion pressures. Those are other markers as well, but those are a little bit, less, invasive. I mean, more invasive and less something that we can actually probably do. But one of the things that I would always say is that if you have a consistent end-tidal that's been now ongoing for an extended period of time, that just basically attributes to basically good, CPR. So if I can get a Lucas device or even, pit crew CPR, and typically it's usually not 70, but it's usually like in the 30s or 40s, where I got a really good waveform capnography, I've got really good consistent end-tidal. That's just a testament to someone actually really doing good perfusion and really good CPR. Now, that being said, what you're looking for now with continuous end-tidals at the same level is a bump. So when I get ROSC or I get some type of actual perfusion that's actually coming automated from the patient, you're going to see a bump in your end-tidal. And to me, that is actually more of an surrogate to where I need to actually probably continue, or where I got maybe some potential to actually me doing some more advanced resuscitation or prolonged resuscitation to kind of resuscitate the patient. But if you're having persistent end-tidals at the same level with no acute changes, then I think that it's still reasonable to pronounce the patient. I wouldn't particularly just say that an end tidal in and of itself should be a reason to keep continuing CPR. You have to look at the whole picture. You have to look at, again, some of the things that we always talk about: early access to, the 911 response system, early defibrillation, early CPR, witness arrest versus unwitnessed. Those are the common things that we look at as markers to kind of determine whether or not we actually have a chance of making that marginal percent of actual resuscitative efforts to ROSC and then actual meaningful neurological outcome. So, in and of itself, an end tidal shouldn't push someone, even it's 70, to continue resuscitative efforts. Now, the other thing is that, again, an end tidal of 70, again, you're trying to make sure that you're actually, ventilating the patient. Is there a VQ mismatch, right? So if there's a VQ mismatch, this gets a little bit more into the weeds of things. You may not be able to get the oxygen exchange that you need, and your end tidals actually stay the same. So, you can blow off that CO2 at the end of the day, but if there's VQ mismatches, then your markers are going to be a little bit different as well. But really, at the end of the day, is going to be changes in end tidal over a prolonged resuscitation that should really guide your care, not so much the number in and of itself.
And a one-liner that that was listed in the role of capnography, that kind of summarizes a little bit what you said. Is EMS clinicians should be aware that end tidal CO2 can be influenced by many factors, as we already discussed, such as compressions, ventilations, etiology of the arrest, medications administered, and acid contaminants in the airway, such as gastric contents, making it challenging to interpret the isolated values without incorporating other information and trends.
Yeah, it's not the end all be all. Yeah.
Okay.
All right, Avil, you're up.
Okay. You guys can hear me. My name is Avulano. I'm one of the EMS Fellows. I'm going to continue with the NAEMSP position statement. The first one that I'm going to go through is the pre-hospital trauma airway management. So the first position statement is the approach to airway management and the choice of airway intervention in trauma patient required an interactive, individualized assessment that considers patient, clinician, and environmental factors. So what are some of the patient factors that should be considered? So those should include initial and repeated assessment for is the patient ineffectively being ventilated? Is the patient apoxic? Does the patient have any type of airway obstruction? Is there a risk of aspiration? Is the patient in profound shock? And another one is the patient having severe cognitive impairment, agitation, mental status. It's very common that in the trauma setting that not all trauma patients are all like limp or almost dying. Some of them can be agitated, especially those with traumatic brain injury. So those are the considerations. The clinician consideration should be clinician experience and comfort level. And the environmental factors, some of the environmental factors that should be considered is the scene safety. If you go to a scene where it's an active crime scene, or do you want to stay there and play around trying to intubate the patient? You have to consider the local resources that are available. Are you going to a tertiary center versus a rural emergency department? So those are like some of the things you have to consider to make the decision whether you should take the patient airway or not. So the next statement is optimal trauma airway management should focus on meeting the goal of adequate oxygenation and ventilation rather than specific interventions. So just like what everybody has mentioned, like the focus now has shifted from like just take the airway to make like an assessment that should I take the airway right now. So the current pre-hospital traumatic brain literature underscored two important observations. So one is oxygenation and ventilation critical to improve traumatic brain injury outcome. while it's intended to optimize care, advanced airway management may not be associated with control oxygenation or ventilation and may be linked to poor outcome. So it's not like being able to ventilate and oxygenate doesn't necessarily that you have to pull a tube. You can use the if the clinical setting is appropriate, meaning if you have a trauma patient that doesn't have any like type of facial traumas or any type of facial traumas that will obstruct placement of OPAs or NPA, you should use those actions to allow for better ventilation and oxygenation. You can use back valve masks. You can use supraglottic airway. You don't necessarily have to intubate the patient because, like they say, advanced airway management can be linked to poor outcome, and the reason being, and we will see in later statement, you try, like if you don't have like first pass success, you have to repeat multiple times. If you don't keep oxygenating the patient appropriately, the patient stay longer in hypoxia, which can be detrimental to the patient. Are you intubating a patient that is hemodynamically unstable? So those are some of the considerations. So another thing that they mentioned is early and aggressive basic airway management, including suction, oropharyngeal airway, nasopharyngeal airway, supplemental oxygen, and assisted ventilation with back-valve mask are the mainstay of rapid early intervention. Again, there's no mention of ET tube. It is good ventilation, good airway positioning, any assisted device that you can use to optimize the ventilation and oxygenation is what you should focus on, not necessarily the tube. Can we go to the next page? The third position statement is management of immediately life-threatening injury should take priority over advanced airway insertion. So basically, unless there's an injury leading to airway extraction, let's say you have like a patient that has like facial trauma, you are concerned for impending airway disaster, patient that has like any type of expanding hematoma, your focus should be to manage the life-threatening injury. Like let's say like if the patient has like is hemorrhaging from a broken limb or something like that, you can control the hemorrhage and helping them maintain the blood pressure, optimizing the patient for the advanced airway. So the TOR, which is THOR, which is the trauma homeostasis and oxygenation research study, consensus opinion is that focus on hemorrhagic shock should be on improving blood flow over oxygenation. So hemorrhagic shock is associated with higher mortality rate. So if you have a patient that is bleeding out, even if you get a tube, the patient is still going to decompensate because you haven't controlled the bleeding. So that should be the focus. The fourth position statement: drug-assisted airway management should be considered, which is DAM, should be considered within a comprehensive algorithm incorporating failed airway option and balanced management of pain, agitation, and delirium. Again, some of the patients that some of the trauma patients, especially those with traumatic brain injury, will sometimes have protective airway reflex, meaning they will still have gag reflex, they can still vomit and aspirate. So it's very important to use those drug-assisted those drugs to assist into optimizing the airway, optimizing the placement of the advanced airway. So one caveat they made is that if you have a patient in hemorrhagic shock, this may alter the medication that you're going to use to assist yourself in putting the airway. So in those cases, you should use lower dose. And I believe the RWJ system has like an algorithm showing like lower dose for people like with hemodynamically unstable and like older people. So that's that's some of the consideration to
Yeah,
keep.
lower dose of sedation, but higher dose of paralytic.
Yes. So yes, yeah, because the sedation is what really affect your hemodynamics. The fifth position statement: EMS medical director must be highly engaged in assuring clinician competence in trauma airway assessment, management, intervention. So what they mean by that is they really emphasize that the medical director should create some type of guideline that's specific to the agency. I mean, every agency is different. Like just like the say goes, you see one EMS system, you see one EMS system. So you should like as a medical director, you should focus on creating guidelines that will work for for your particular group, because you know your staff, you know how to um, help them be successful. So you should the medical director just should be to create guidelines that's specific to the agency, and also to the specific clinician expertise and experience. The specific clinician expertise and experience should be taken into consideration. In doing so, it's been documented that there is a positive effect on actually using said guidelines. So if you implement guidelines that takes into consideration your clinicians, they are more likely to follow those guidelines compared to just pulling something out of the blue. The guidelines should also describe when to escalate the airway management, what is the airway goal and the targets, and the choice of appropriate patient destination and potential mode and threshold when applicable. So it's not just like, oh, you should use this airway, but also it should go into further into deciding, like, okay, I have a patient with this particular condition. When do I go to a trauma center versus do I go to is it safe to transfer to the local ER? Next slide. So the next position statement is optimizing physiology during pre-hospital airway management. So that ties into what we were talking in the first position statement I was mentioning. So airway should be approached as an organized system of care, incorporating principle of teamwork and operational awareness. So teamwork, that's the key word here. So effective teamwork span multiple competencies, including communication, which is key, leadership, team coordination, and decision making. So like an example of effective teamwork technique is direct and closed loop communication. So this is something we see in practice a lot in the ER and even in the pre-hospital setting, especially when we have two medics working. If one draws the med before either the person administers the med or reads back to the person that's going to administer the med what was drawn and how much was drawn. So like the direct and closed communication to avoid like any type of error. Verbalization of airway management plan and ongoing situational awareness to ensure shared mental model. So basically, it's encouraged to have, prior to having to get in on scene, to have had like areas like what would be what would be the how do you say the steps that we take if we encounter this particular situation. Also, it's very important to use checklists, because if you use checklists, if you do the same thing the same way every time, you are less likely to miss anything. And also, like after big event, like essentially you have a traumatic patient that you have to take the airway, you have to stabilize and then transport. It's very important to debrief after the fact, because then you can go over, okay, what we did what was done right, what was done wrong, and like how can we improve, and what we can continue doing. The second statement: EMS clinicians should prevent and correct hypoxemia and hypotension prior to advanced airway insertion. Before intubating anyone, you should always make sure to pre-oxygenate. So pre-oxygenation prior to each attempt provide additional safe apnea time to minimize the occurrence and death of hypoxemia. So the better the patient is pre-oxygenating prior to intubation, that allows you more time to for success when attempting advanced airway management.
This stuff that we've been doing for at least the past couple of years. Remember, this is a position statement that's being put out to the entire nation. There's some places that still don't have drug-assisted airway management. There's some places that haven't optimized their system. So some of this may seem like basic, but that's the point of a position statement, is to be like, hey, at a minimum, if you're doing pre-hospital airway management, you should be working to have these things solid, which I think for a bunch of these we already do in our different systems.
No, go back. I'm still on the second. Yeah. So can you click on the link, please? Okay, so this is the oxyhemoglobin dissociation curve, and if you see like anywhere between 195%, there's really like little decrease in the PaO2. But once you go below 94%, it be like the curve dip significantly. So that's just to say that you should always aim to oxygenate above 94%. And again, if you're in 100%, that allows you more time, more oxygen. It allows you more time to essentially to be able to intubate the patient, because the patient remains, the oxygen content in the blood remains higher, but once you go below 94%, you start dipping down. So that put the patient in an increased risk of hypoxemia. Okay. Good. Next.
So continuous physiological monitoring must be used during airway management to guide the timing of, limit the duration of, and inform decision making during the advanced airway.
Yes, I think.
So this goes back to what they were saying before. Where you want to optimize hypoxemia and hypotension. So use and push those pressors, pre-oxygenating the patient.
Yeah, so sorry, I kind of swathed that a little bit. So essentially, so it's very important for the clinician to, again, you should always monitor the pulse ox and make sure the patient is not desaturating. The goal is to ensure that there's a decreased apnea and apopnea time, which is associated with increased poor outcome. You also want to continue monitoring the heart rate and obtain frequent blood pressure, because you do not want to run the risk of as you're trying to intubate the patient becomes bradycardic and hypotensive. That increase your risk of patient coding while you put in the tube. The goal should always be to limit the duration of our advanced airway insertion attempt. So you don't want to fumble around, wasting time trying to get the tube, forgetting about the other vital signs like heart rate, blood pressure. The fourth position statement: initial and ongoing confirmation of advanced airway placement must be performed using waveform capnography. Airway device must be secure using reliable method. So waveform capnography not only can be used to confirm initial placement, but it's also the best method for ongoing monitoring of airway positioning. So this may not be true for us up north where we have like very short transport time, but like when you go more south where they have like longer transport time, and you know, depending on like is the patient moving, is there a lot of movement in the back of the truck, you have a great chance of dislodging the tube. And if you have with the waveform capnography, you can keep like you can have like constant feedback on where your tube is positioned. As far as securing the endotracheal tube, there are multiple ways you can do that. You can use like adhesive tape, ties, and there are commercial airway device holders. This is what we use in the system. They are all acceptable. However, there's a recent single center randomized controlled trial of lens purger and which observed that there's a low rate of ET tube dislodgement with the use of commercial tube fastener as compared to tape. So I mean that goes without saying. You know, again they made the caveat that it's all provider utilizer dependent. Some people have practiced with the ties and the tape. They've been doing it for years. They know how to secure the airway, so that's fine. They know what they're doing. But like, you know, so with them there might not be a problem. But like, you know, that's not the case for everybody. But with the commercial airway device, it's that like doesn't matter what the experience level. You know, your chances of dislodging the airway is very low. Next page. The fifth position statement: perfusion, oxygenation, and ventilation should be optimized before, during, and after advanced airway insertion. I mean, that goes without saying. You know, you like constant monitoring and correcting any abnormality as patients being transported should be the goal. 6. To mitigate aspiration after advanced airway insertion, EMS clinicians should consider placing the patient in a semi-upright position. This is early survivor of cardiac arrest and trauma are at high risk of in-hospital pulmonary complication, including ventilator-associated pneumonia, ventilator-associated lung injury, and ARDS. So this is something that is seen commonly in patients. There are numerous papers that encourage that that patient head be elevated above 30 degrees, and they're seeing that there's a decrease in incidence in ventilator-associated pneumonia in the intensive care unit. Even though those data are from the inpatient side, it can be extrapolated to the to the pre-hospital setting. And it just makes sense. This is just physics, right? If you have a patient laying flat, it's more likely for whatever gastric content to come up and get into the airway compared to if you have a patient sitting upright, unless you jump on the patient's stomach to create like a force to push like whatever gastric content to go up. Like it's very you have gravity working for you. So this is just physics. It just makes sense. So I think the 7 position statement: when appropriate patient undergoing advanced airway placement. When appropriate, patient undergoing advanced airway placement should receive suitable pharmacologic, anxiolytic, anesthesia, and analgesia. In select case, the use of neuromuscular blocking agent may be appropriate. I mean, how many times have we intubated someone and we notice that they're tachycardic, you know, they're hypertensive, some of them are tearing, and we wonder why. And the reason is because like having a tube down your throat is uncomfortable. it doesn't matter whether you sedate it or not, it is very uncomfortable and it is painful. It is potentially painful. So I think it's just ethical, to address patient pain and make sure they are comfortable, and you're doing so by appropriately giving an anxiolytic. Like in this case, you can, like in the pre-hospital setting, we can do um, post intubation with ketamine, or like what we love to use in the inpatient setting, Versed. And then for the pain, fentanyl. If you give fentanyl for the pain, the patient, you will notice that the patient vitals will start stabilizing because now they're more comfortable.
Yeah, just remember that fentanyl alone is not enough.
Yeah, it's not enough. Like you have to give something else. So in addition to reducing patient anxiety and pain, those may also prevent brain injury and lower intracranial pressure. Like I said, you intubate the patient, you notice they're tachycardic, they're hypertensive, so you do all those increase the intracranial pressure. So if you have a patient that has traumatic brain injury, that will contribute to worsen the outcome. So it's very important to treat the patient in pain and anxiety. Some patient will once you intubate, you will find it to be difficult to bag. In the right patient, you can use like more how do you call it? More paralytic. This is something that is done a lot in the ICU, especially when patient is desynchronous with a vent. Once you paralyze them, you tend to see that they tend to be, that tends to mitigate that. That can be done also in the pre-hospital setting. If you bag the patient and you find it difficult to bag, maybe like pushing the paralytic can help mitigate that. Next.
For the most part, we might use this during like a STCU transport, but
Yeah.
usually in the case of like a emergency where we just RSI the patient, we're probably not going to give additional neuromuscular block.
Yeah, typically the effects of the paralytic will pretty much last during a transport for a 911 kind of transport. That being said, the one patient that I would really hone in on and make sure that appropriate paralytics are given is the patient that you end up reverting to maybe possibly a surgical cricothyrotomy. That patient that you've had to secure a cric on, that airway you don't want to lose. And so until that patient has a definitive trach placed, even after pre-hospital setting in the emergency department and even in the ICU setting, these patients are paralyzed until they can have definitive airway management with a tracheostomy. So that patient specifically, you have to make sure that there's no chance of losing that airway. And so paralytics and the effective use of that paralytic is paramount in that scenario.
So next slide. So this is the persistent statement of novel technology and technique in pre-hospital airway management. Essentially, those are what the NAEMSP expect. Expect like the minimum that should be expected whenever you're about to use when you're considering using novel technique for your pre-hospital airway management. So the first one, prior to implementing a novel technique or a technology or technique, a thorough assessment using the best available scientific data should be conducted on the technical details of the novel approach, as well as the potential effect on operation and outcomes. I mean, that goes without saying, like, before before using anything, you have to do the proper literature research and make sure that you also have to make sure that it's cost effective. Number two, the decision and degree of effort to adopt, implement, and monitor a novel technique or technology in the pre-hospital setting will vary by the quality of the best available scientific clinical information. If you go to the next page. So essentially, things that are routine use, those technique and technology with ample observational but limited or non interventional clinical trial data or with strong supporting illustrative data. This technique may be reasonably adopted in the pre-hospital setting. This includes visual laryngoscopy and bougie-assisted intubation. So, like for visual, I mean, doing research in the pre-hospital setting is it's not the easiest thing. So a lot of the inpatient research can be extrapolated in the pre-hospital setting. So with video laryngoscopy and bougie assisted intubation, those are, we have like great data and supporting like first pass using those techniques. So it's those can be extrapolated in the pre-hospital setting. Data with limited use. So technology and technique with ample pragmatic clinical use information, but limited supporting scientific data. This technique may be considered in the pre-hospital setting. This includes suction-assisted laryngoscopy, airway decontamination, and cognitive aids. Those that are of rare use, technology and techniques with minimal clinical use information. Use of this technique should be limited in the pre-hospital setting until evidence exists for more stable clinical environment. This includes intubation box. I mean, going back to the intubation box, this is something like we use a lot inpatient for intubation during COVID, but like we did use it thinking that it was gonna be protective, but like data's later come out showing that like you increase your exposure, especially for the person intubating the patient. So those kind of these cannot be extrapolated in the pre-hospital setting. Like those definitely. Next page. In the use of novel technology and technique must be accompanied by systemic collection and assessment of data for the purpose of quality improvement, including linkage to patient clinical outcome. Again, every decision that we make in using new techniques should be with the good of the patient in mind. Like you should always trying to improve the patient outcome, and you have to have the right research to back that up. And finally, EMS leaders should clearly identify the pathway needed to generate high quality supporting scientific evidence for novel technique and technology.
Yeah, this entire thing is, some of it may seem like, oh, of course you should do that.
Yeah.
Problem is what we've seen, like look at the intubation boxes, is when you're put into a situation where, oh crap, we're trying to protect our people, this sounds like a good idea. Hold off. Let's if we're going to use this, let's study it. Let's figure out, is it actually helping? It shouldn't just be, oh, the newest, shiniest toy is going to make everything better, and then we find out, oh, actually it doesn't.
Yeah.
Actually, it's causing more harm.
Yeah, and sometimes like the most expensive toy doesn't necessarily mean that is the better toy. So you always have to do your due diligence before you start implementing your system.
All right, we're past the halfway mark. We got Dr. Deacon up.
Good afternoon, everyone. Can you hear me?
Yep.
All right, perfect. So I'm also carrying out 3 parts of this compendium, and the first one we're starting off with is the stance on non-invasive ventilation. Next slide. So basically, NAEMSP made some recommendations in regards to this, only because we realized of the benefit that it has in the ER setting. We've realized that even in ICU settings, and it's been introduced on the ALS level at times, but now they're actually highlighting and agreeing with the stance that there's actually could be some benefit at the BLS level to improve patient outcomes. Back in 2019, it was introduced as part of the scope of the practice model for EMTs. So that kind of stirred the positives as well to kind of get this out to the masses. For the first standpoint, basically, They realized that non-invasive should be used in management of pre-hospital patients with respiratory failure, such as those with COPD, asthma, and pulmonary edema. We know basically how it works at this point now that we get the positive airway pressure ventilation, stents open the alveoli, helps disperse some of the fluid in the case of pulmonary edema, and it allows for improved gas exchange. Part of the concern they had with this was how this positive pressure can increase or create the excessive intrathoracic pressure. And because of that, there was concern about, decreasing the cardiac output because we're dropping the preload with all the increased thoracic pressure. So they looked at it as, would this be a little bit too much of a BLS scope? Because what would be the next intervention? Part of this hesitancy as well in the past times was, could this positive pressure exacerbate some underlying conditions, like if the patient happened to have a pneumothorax or pneumomediastinum? So they looked at about 125 articles and kind of summarized that there's still more benefit than there is risk overall for introducing non-invasive in the pre-hospital setting continuously, even down to the BLS level. One thing they happened to appreciate was that with the use of it, early use of non-invasive, that did decrease the work of breathing in a majority of patients, and also the need for intubation in a number of patients. They highlighted a French EMS system where there was physician staff in the system as well, significant decrease in intubation rates for patients with pulmonary edema after applying CPAP in that setting, and even in the Australian system as well, to where they looked at just over 700 patients with respiratory distress, and they randomized them between their standard of care, which is just like a face mask or non-rebreather, compared to those with CPAP, basically. And they realized that there was really no difference in mortality of the patient or length of hospital stay, whether ALS or BLS performed the CPAP, but they did note that the amount of intubations did decrease. They had one more point here, and they did note that there's basically just a lack of evidence on the pre-hospital side that to compare as far as CPAP versus BiPAP at this stage of what's really better for the patients. The next standpoint is a non-invasive safe for use by the EMTs. And basically, Wisconsin was one of the first, if not the first state back in 2005, that was kind of involved with this. So they implemented this pilot program to get BLS to use it. And basically, after a year of studying it, they realized that the outcomes were very similar to the patient outcomes, that is, were very similar to who still needed advanced airway, so further intubation, or those who didn't, whether ALS or BLS placed it. So they started to pick up this pattern that, hey, it's probably not that bad for BLS. And then in Delaware or Denver, I think it was Delaware, basically they had a pilot study program as well, 4-hour course, which was just 2 hours of didactics, followed by 2 hours of a hand-on process, just to see if the EMTs can grasp the concept and proper application and use in this. So again, they had to use the same indications and contraindications, and then they evaluated afterwards, after this pilot study, as to whether or not the EMTs properly use it in the right settings. And throughout 1 year, they had a total of 74 patients who BLS applied CPAP to. 100% of the patients, it was correctly indicated for them. And they were all appropriately monitored until ALS arrived. Of the 74, 89% of the patients had overall improvement after CPAP, and no 6% unchanged, and only 4% worsened. Overall, 84% of the patients basically, there's a reduction in 84% of the patients who had O2 sats that didn't drop below 92. So again, it's something that they see that was easily taught, can easily be applied, can easily be retained, and can easily be followed to see patients improvement with this.
And we all know that, withholding care from a patient because you're worried that you're going to harm them is not necessarily the right answer. You want to make sure that you're not causing harm. And what these studies have shown is that we're not causing harm by putting them on BiPAP. It's a little bit before my time, but there was a time where every single person in respiratory distress just got intubated, both pre-hospitally and in the emergency room. And unfortunately for emergency medicine residents and new paramedics, once we introduce non-invasive ventilation, intubations drop precipitously, which I mean is good for the patients, bad for procedural skills.
Yeah, I definitely hear you on that. And it's a good thing that this technology has come to this, because at the end of the day, it goes back to patient centered, what's best for the patient. At least it's still bringing this in as a BLS skill. There's more push. One, again, gives that patient that extra 5 minutes of staving off intubation until an ALS arrives. Those 5 minutes without treatment can make the world of a difference. What comes next for that patient?
Yeah, one of the comments is the nasal intubation. Personally, that was before my time. I don't know how to nasally intubate a patient. The people who know can literally just put it in. Yep.
It was a technique that we were taught back in our initial training, but that was in 1992. That anybody in CHF that wasn't responding to some sort of pharmacological intervention automatically got nasally intubated. You just put that tube in the shape of a C and you lean them forward, and when they exhaled, you push the tube until it went into their lungs.
Yep. And
they
the
can
thing
definitely
is,
change.
I've seen it work. Would I try it personally myself? No, because I don't have that procedural skill. But the people who know, it works very well.
Yeah, if you got them, to accept the tube, it took a lot of coaching, whereas, as you just said, CPAP is a much better alternative than nasally intubating someone, because the tube is a smaller tube and you just weren't getting the oxygen delivery, and the outcomes were much poor.
Yeah, definitely. And those, even with a significant amount of pulmonary edema, we've seen all that pink froth come up into the tube. So you work with a smaller tube in the nose. I mean, it's only going to do you but so good for so long. So it's good that at least, or just early CPAP, it's going to be that thing to really hold them over. The next stance is medical directors must assure adequate training in non-invasive ventilation use, including appropriate patient selection, non-invasive system operation, administration of adjunctive medications, and assessment of clinical response. The stance kind of overlaps between BLS and ALS care. Definitely know, ALS has more comfort with it, and we, even within our regions here, we do see it applied quite often and does well for the patients. I can't recall in the last 2 years, that's finishing residency, coming into fellowship, a CHF patient who came in on CPAP or BiPAP who needed to be intubated, because it's been that great for them with other adjunctive medications. It's been the ones we kind of hated as residents, because we're about to get that tube, then you learn some good resuscitation, CPAP or BiPAP, and some good nitro and other medications. And then before you know it, you can turn this patient around in minutes, just dropping the pressure by, a good 20, 30 points systolic, and just helping them to calm down. They're no longer diaphoretic, they drop pretty quickly. We realized patients did much better with this. So part of this as well, oh, sorry, I lost my page here. So part of the education for them as well is going to be, again, reinforcing that with the BLS EMTs, because for many, this will be a new skill for them. We see it's hard enough, just to get everyone through competencies at times. But still, just one of those things we have to push, that if it's going to be a skill that's introduced to the masses, again, it's practice, practice, practice. And sometimes the harder part of this, especially if you just have a simple, you have the mask that you're going to hook up to an oxygen power system, rather than a turbine or anything battery powered, the hardest part is probably just going to be coaching that patient into a smooth application of it. Going to say, put it on to get that first gush of wind into the face. It kind of makes them a little more anxious in itself. The respiratory distress gets a little worse, and then that could kind of set you back a couple steps. So not only an EMT familiarity with the device, but also how to coach that patient in first-time application, patient true distress for it. And again, continuing education for ALS clinicians as well. One, early use. If patients be intubated, again, your spidey sense is already kind of going off, but you still kind of have this algorithm, and you're using all your adjuncts: positive pressure, venodilators, arterial dilators, and this multimodal approach, better outcomes for patients. Next statement is medical directors must implement quality assessment and improvement programs to ensure optimal application outcomes. Again, this goes back into the QA/QI. As easy as we query different cardiac arrests and other various calls, these are the same things that can be pulled every time, CPAP is applied, or anytime someone's getting nitro or even Lasix in itself. It's just, let them use it, reevaluate it, teach them, track the patient outcomes. It becomes pretty somewhat easy to do because you can see where non-invasive was applied, and you can see the end of it. Was the patient intubated or not? But that itself could kind of let you know how your patient did, and just really looking at the vitals as well to see what that respiratory rate, where it changed from. They're tachypneic, they're tachycardic, labored, they're hypertensive, but after application, those vitals kind of come down and normalize as well in conjunction with the patient's condition. And the last one on this one was that novel non-invasive methods such as high flow cannula or helmet ventilation may have a role in pre-hospital care. True, there are a couple of studies, some from the UK, that they looked at if we don't have non-invasive like CPAP bypass, or if you don't if you don't have this positive pressure, really could a high flow nasal cannula be just as good, or the helmet? In some instances, yes. There was a Flow Rally trial that came out not too long ago, and basically they looked at patients who are hypoxic, so just hypoxic respiratory failure. Those patients who got high flow nasal cannula, so at least 50 liters a minute flow, versus those who got standard non-rebreather, versus those who got positive pressure ventilation, and who needed intubation. In this one particular study, those who got high flow nasal cannula, less of those patients needed intubation. But then again, the comorbidities of patients were quite different in themselves. And these were just patients who were hypoxemic. So it could have been for various reasons why they just need a little oxygen and not necessarily positive pressure in that sense. So that's it there. And the last part of it for the novel tools, they look at the helmet. It's basically like a hood the patient will put on there, and you can flow oxygen through it. The big downside to this was that using this helmet, you create so much more of a dead space, and now you're going to need about at least 60 liters of flow just to erase that dead space, so you don't rebreathe all the CO2. So again, pros and cons. Is it useful? Yes, but cons, again, a little more expensive. You're going to use up a lot more of your oxygen supply. So for majority of situations and EMS systems, it's probably not going to be the most cost effective. So again, your regular, not even turbine powered, but just oxygen powered CPAP mask device should suffice to hold off intubation. Any questions on this stance? Okay, move on.
Yeah, move on.
All right, let's go to the next position. Along the same lines, NAEMSP made recommendations on mechanical ventilation. Majority of patients who get advanced airway in the field tend to have manual ventilation, so being bagged with BVM through their supraglottic or endotracheal tube for various reasons, whether it's commute, distance, supplies, whatever be the nature. But they're taking a stance to recommend the use of invasive mechanical ventilation for hypoxic and hypercapnic respiratory failure, and in the cases of airway protection. And the goal is, and why they're pressing that is, because when you hook someone up and you're bagging with the BVM, you're just at a more risk of inconsistent volume, inconsistent pressures. There's going to be times where if you don't, the right amount of staff around you, patient may not be bagged or ventilated appropriately for a couple breaths. So you there's just too many areas of error that can be made there. So looking at the data, that hooking these patients up to mechanical ventilation lowers the risk for barotrauma versus the risk for inconsistent volumes and ventilation in itself. So first point is that EMS clinicians, including those performing emergency response, as well as interfacility response, should consider using it after advanced airway insertion. Again, it's going to be best practice for ventilation to prevent the ventilator-associated lung injuries, because we have an option of set in certain volumes, those lung protective volumes. So again, a predicted body weight of 4 to 8 cc's per kilo in itself, with maintaining plateau pressures less than 30 centimeters of water, and also driving pressures of less than 15 at least. Again, protect the lung, and through the minor adjustments and whatever underlying disease the patient has, you're going to have more lung protection while still getting your adequate ventilation and oxygenation. Again, and we've spoken about it a couple of times as well, that the amount of barotrauma you can cause with a simple BVM is it's not hard to do. Again, adult size BVM, it's like an easy 800 mLs of gas through one squeeze, which if you look at your average, and they mentioned it here, 70 kilogram man who only needs about 560, again, easy for barotrauma. And if you're going to do that, 15, 16 times a minute for your next 20-minute ride, you may not be doing a patient significant justice. So again, use of the pediatric bag. They checked in a study in your adult size 70 kilo person, even ventilating them with a pediatric bag. The simulation detected that the patient was only getting the appropriate volume only 17% of the time. So even with the PD bag, you can still max out about 650, almost 700 mLs of gas. So again, even more reason to advocate for using mechanical ventilation, just to control these parameters there, so we can offer more benefit to the patient. They looked at the management, mechanical ventilation management, and kind of different groups of people. Also, for those with just this hypercapnic respiratory failure, again, make sure we're adjusting it for the minute ventilation that they recommend, so we get the proper oxygenation and ventilation as well. Again, lung protective strategies. And cardiac arrest, recommended mechanical ventilation at about 10 times a minute. And then once you get ROS, try to maintain saturation between 94 and 98%. As we already know, it's proven that hyperoxia can also impair neurological outcome. In traumatic patients, they definitely recommend strong resuscitation for intubation if possible. So make sure we control it all bleeding as well, because again, once we intubate and we start this positive pressure ventilation, again, we're going to increase intrathoracic pressure and also decrease our preload. And you definitely don't want to create any barriers to a good resusc for this person. And again, also with in neurological cases, so patients with TBI, the goal there with mechanical ventilation is to try to avoid these secondary brain injuries. So again, the hypoxia, the hypocapnia that we may get from the excessive or underventilation of the patient. And a point they highlighted here too is also that not to solely rely on the Glasgow Coma scale when it comes time to intubate a patient, especially TBI patients, because for interfacility transport, you want to look at how long your commute is going to be, try to anticipate any potential hiccups, use of supplies, equipment, personnel. So if it's safer for the patient and for the teams to intubate the patient, though the GCS may be a little higher than 8, recommend and just take everything into consideration, because that may be more beneficial as well for the patient. So the next point, pre-hospital mechanical ventilation techniques, strategies, and parameters should be disease specific and should mirror in-hospital best practices. Again, similar to what we're saying, it's all going to come down to what patient you're dealing with. So whether it's your trauma patient, your respiratory patient, or cardiac patient, you want to have controlled yet optimized settings so the patient can get the best outcome. Statement 3, EMS clinicians must receive training in general practices, in the general principles of mechanical ventilation, as well as detailed training in the operation of the specific systems used by the agency. That really speaks for itself, and they didn't divulge much into that. Again, every EMS system is different, so it's good to just always follow your protocols. But at the end of the day, each of these protocols should have some resemblance of each other, and again, lung protective strategies, preventing secondary brain injuries.
Yeah, for number 3, I think it's trying to address that, understanding, what is PEEP, what is I to E ratio, things like that. And then specifically, how that applies to the equipment that you're using as well. So am I using a Hamilton vent? Am I using a LTV vent? Things like that. And actually, unfortunately, sometimes within the EMS system, we're using multiple different vents. So do I know how to use the equipment that I have?
Understood. Thank you. And for the last statement, patients undergoing mechanical ventilation must receive appropriate sedation and analgesia. I think Dr. Engel's statements kind of overlapped on this as well. Again, it's going to be key. They definitely advocate for analgesia first model. So before we introduce any additional paralytics or sedation, we should definitely make sure that we've appropriately managed the patient's pain. And one thing they highlighted, which I think kind of resembles what tends to happen in the ED as well, is we shouldn't be lowering someone's sedation or pain medication because it's making them a little too hypotensive. We should maintain that degree of sedation and adequate pain medicine. And if they're becoming hypotensive, we should initiate pressors or a fluid bolus, whatever it takes to sustain a perfusion and not compromise the pain or sedation. And that's one thing when you read it, like, yeah, it makes sense. But if you're looking at practice, sometimes it tends to like kind of hesitant to say, okay, put in another line so we can get pressures going. It's just easier to kind of turn down sedation to get rebound effect. Then we notice, that they have a little tear in the eye, they're tachycardic, their pressure's coming up, they're triggering the vent, they're a little restless and uncomfortable, or start bucking. So that's definitely something to note as well. So a summary for this position overall is, for those who do get intubated, adequate pain and sedation, maintain lung protective strategies, know your equipment, prevent secondary injuries, and try to introduce more mechanical ventilation so we can properly control the parameters to prevent barrel trauma. And if there are no questions, we can go on to the last position, which is looking at pre-hospital surgical airway management. And basically what they're trying to highlight here is that the pre-hospital clinician should definitely go out already with an algorithm or a game plan in place. They definitely say that it's a reasonable thing to get a surgical airway in the pre-setting, in the hospital pre-setting, when you can't secure by any other less invasive means. So we've passed a window where we failed non-invasive ventilation, supraglottic can't sit right, and then we can't get the endotracheal tube in, so your next thing is going to be that surgical airway. And the key is that you have to have a plan to get to that point and kind of commit to it. So be comfortable and have that already in your arsenal, ready to go. Because when it's time for it, you should even delay. Because not only that, it could just be, for instance, that patient to where there's significant facial trauma or burns, and you can't put on a CPAP, or you can't intubate them from above anyway, so you will have to perform that correctly, so you should be prepared for it. On the next page, I think I have a chart there. We can go to the next slide. So this is kind of what I prelude to. This is not necessarily they're suggesting, this is just an idea of a cognitive aid to kind of assist pre-hospital clinicians and kind of having the algorithm. Kind of works well for most people and with most things, because if you do 1, 2, 3, and you've truly attempted those, your next bet is to commit to step number 4, because you've tried everything above you. So having this type of aid, I think, will kind of help the pre-hospital clinicians become a little more comfortable committed to supraglottic airway. So here they recommend starting off with like a pre-oxygenation airway checklist. You're going to attempt intubation, whether you do it awake or RSI, and then you see where your O2 saturations are. If they're less than 90%, you want to go ahead, and now we're below the line here. You want to go with your BVM, try to ventilate and oxygenate them. If that's adequate, you bounce back up to your SATs above, then you can try your RSI. In the instance that that's inadequate, again, one, try for supraglottic airway to try to recover. It's adequate. Now we go back up above the black line there, SATs improve. And at times you can probably just secure your supraglottic airway. Once you have a nice fit, you can get a decent entire reading and oxygenation. You may be okay there. But if you can't, then again, we're looking at now moving on, since we failed in the tracheal intubation, and you're going to your surgical airway. They don't necessarily discuss the full set of skills or the approach. But one thing they recommended through various studies is that there tends to be a preference and there's more success in using just that open scalpel, that blade, along with the bougie inner 602, rather than trying jet ventilation or any of the cellular technique models in itself. While your catheters get kinked or bent, there's depth issues, there's placement issues in itself. But with the scalpel, you cut, you find your landmarks, you cut, you expose, you go right through the membrane. Success is greater there because you still have the bougie as a backup you can introduce and maintain patency as well. And with that, they don't want us to consider the surgical airway as a substitute. It's part of an algorithm. It's a next step, not necessarily a substitute. So we shouldn't be cracking or doing surgical airway on anybody who kind of easily attempted intubation with first or a supraglottic airway. It's not that you pick and choose. It's a stepwise approach because of the invasiveness of the procedure and the risk of complications associated with each step. And then number 4, success of an open surgical. Again, kind of jumped the gun on this one of using the scalpel is higher than that of a percutaneous or jet ventilation itself. Part of the downside with the jet ventilation is that one, there's certain adapters or connective pieces you have to make sure you actually have that fit with your mask. And then also the degree of barrier trauma they actually realized was pretty significant in these patients as well, because you're still trying to bag harder through now a smaller catheter. So there was a downside. So summary for this standpoint, again, have a game plan, always be prepared to perform a surgical airway. It should be a part of a stepwise algorithm in your head. So pre-planning is key. If you're going to cut, again, a recommendation is with a scalpel and a bougie. However, still have to abide by your agency's protocols. If there's controlled pryke or whatever methods you have, follow agency protocol. But just be aware of the downsides to using your equipment pieces. And that really covers it. Any questions?
So, if there's any questions, go ahead. I just wanted to highlight, the reason why they made this pre-hospital surgical airway management an entire section in this compendium, was because it's one of the things that we've been talking about for the last 5-10 years. A surgical crike is part of your algorithm. It's not a failure of your ability to manage the airway. It's a failure of, we were unable to intubate from above. So we went with the crike. It's good patient care to actually do a surgical crike. And by putting this in its own and making these statements, it's making it okay for an EMS clinician to actually perform a surgical crike. One of the things with a surgical crike that we talk to our paramedics about, that we talk to our residents about, is that it's part of the algorithm. I have an experienced provider intubating from above. They just failed. We're already starting to figure out, okay, we're moving to this backup technique. We're moving to this backup technique. And okay, those failed. Now we're criking. It's not, oh, we didn't think about criking, and now that we failed 5 times, the patient's hypoxic, they're not breathing. Now maybe we'll do a crike. No, it's on the algorithm. This failed, we tried this. We went to supraglottic. Supraglottic failed. Okay, we went to bougie. Bougie failed by an experienced provider. All right, start cutting. It's not we're waiting for the patient to have hypoxic brain injury. We're going down our algorithm. All right. Dr. Shi. Nope.
This ties back into, like I mentioned, the cognitive aspect of it. It's kind of having a set algorithm, a mantra of how you're going to do things, and then also kind of, having the mental fortitude to make that decision. Sometimes the toughest decision is the decision to act, and that in and of itself is the hardest choice. This comes with, a crike. This comes with doing, a lateral hemithoracotomy. So all these types of things where you have to make a decision to act in a very, invasive way. You have to have the fortitude, and you have to have the kind of pathway set in your mind that says, yep, if we don't do A, B, C, we move to D. And so, making it a part of your algorithm, having a stepwise process and fashion of how you're going to do it, mentally preparing yourself. This is all part of that cognitive awareness and kind of, really kind of offloading yourself from having to say, should I not? It should be, yep, this is the next step in my pathway and this is what I should be doing.
So we're on the home stretch. Dr. Shi is doing the last three and focusing on pediatrics.
Can everyone hear me?
Yes, we can.
Okay, if you've made it this far, I commend your endurance. We will be talking about the NAEMSP position statement on pediatrics airway and quality management, as well as training. I think, if we really boil it down, besides the getting lost in the details, really what it comes down to is this. Paramedics and EMS clinicians need to be trained in recognition of respiratory distress early so that the appropriate non-invasive, if possible, intervention can be done to prevent and reduce invasive ventilation. The other key is having an honest look at your own system and agency and seeing, do you actually get enough practice / training, sim training, etc., to really develop competency and maintain competency in a high acuity, low occurrence event that has questionable benefit in most cases in the field. The last thing another thing the position statement sort of really delve into is making sure obviously enough and appropriate equipment is used that's appropriate for the size of the child. And lastly, making sure that developing sort of QA/QI metrics that are more nationally recognized in order for us all to have a good way to set standards in a field that has a relative sparsity of data compared to the adult side. So we'll start with the first section, pediatric respiratory distress, airway management, training and education. I'll kind of breeze through some of these parts because, again, you can read these on your own. They go over some physiological factors that make airway in pediatrics challenging: poor O2 reserves, increased metabolic demand, the size of the head relative to the body, the size of the tongue, etc. They recommend reading Violette et al., which has a good description of pediatric posture as well as pediatric oropharyngeal structures in pediatric airways, as well as Goya et al. And D. Seco et al. For physiological differences between adult and pediatrics. They recommend the pediatric assessment triangle for assessment of children for early recognition of an impending airway using appropriate equipment, O2 and capnography, as well as really stressing, again, early recognition of respiratory distress so that non-invasive interventions can be used to prevent a potential airway disaster later on. In fact, a study of 420 paramedics with a case-based questionnaire showed that 92% of the time they could correctly identify respiratory distress, which is good. However, only 50% of the time they could really identify the physiological process, whether that be croup, asthma versus foreign body, as the cause of their respiratory distress, and only could do the appropriate intervention 38% of the time. So clearly training and education needs to be improved in these areas. They next go into, in part 2, they go into the different sort of categories of airway. They broadly break it up into 4 categories: upper airway, which is stridor, foreign body obstruction, etc. Lower airway, which is more, we're thinking about bronchiolitis, asthma, cardiac causes, of respiratory distress, and then extrinsic causes like respiratory alkalosis from a concurrent metabolic acidosis, or hypoventilatory causes like head trauma, seizure, or toxidromes. We'll skip past that in terms of the very big details about that. Differentiating between hypoxic and hypercapnic with using both a concurrent use of the appropriate sized O2 monitor as the pulse ox from an adult monitor. It may cause an inaccurate reading, and also use of end-tidal CO2 to ensure that you're monitoring for hypercapnia in the patient. Then lastly, they go over this part was pretty eye-opening about success rates, or the amount of endotracheal intubations that are needed to maintain or even develop competency in this procedure. Again, this is something that's not routinely performed and not something we manage every day in most regions. An article by Toida et al., published by Japanese paramedics, showed that less than 13 intubations had little effect on their performance, while about 31 intubations were required for a 90% success rate, and 38 were required for a 95% success rate. And these paramedics were performing on live children in the OR, an opportunity that is not had by most paramedic training programs, especially with so many learners, NPs, medical students, residents, fellows, etc., competing for these opportunities. So again, the cost of just training up EMS clinicians to get competency to that 90%, 95% mark may be prohibitively high in your system, and has to be evaluated.
More importantly, that's in the operating room, where it's controlled environment. You can adjust the height of the table. You have the lights. The patient's been pre-opt, so there've been NPO, plus or minus some sort of gas sedation to facilitate your intubation. And this is why some systems have taken pediatric intubation out of the hands of paramedics, which, I mean, personally, I think is the wrong answer.
Yeah, actually, we'll discuss this later on, but they also had discussions in their own, the first authors of these articles put out a podcast discussing their sort of views. And one big thing that was talked about was whether or not pediatric intubation should be in the routine wheelhouse of paramedics, and depending on the agency and depending on how much practice and work you get into it. And some of the authors said that in their agencies, they decided that they could not maintain the educational requirements to keep their paramedics well trained in this. So they went with subglottic airway as the preferred method of invasive airway for children in their prospective agencies. Wang et al. In 2004 published another study of paramedic students across the US, and of all these national paramedic training schools, 70% of the students only had 10 endotracheal encounters with peds, 20% had 20, and only 9% had greater than 20. And they found the success went from 87% to 95% when endotracheal intubation was about 30. So it seems that about across all these papers, that 30 intubations is that magic sort of number where performance really starts to, and competency really starts to increase. But then maintaining that is another question, and not an answer we have right now. They go into education on trachs and vents, which is another that EMS clinicians should receive special training for these technology-dependent children and special care kids. We can go to slide 2, please. And again, still stressing the using the least invasive strategy for the least invasive and most effective strategy. Why intubate a kid when, you know, bubble CPAP or high flow or just calming the child down is effective? And I think really making sure that that is emphasized rather than, as Jesse said, having a endotracheal tube centric education where you have this goal of getting the tube down. It's great because you high five each other and you feel great because you've achieved the goal, but have we really done the best thing for the patient? And I think that's where we should be shifting our focus when we train EMS clinicians. The second part, we talk about the paper talks about skill decay, which is a very fascinating sort of area. A study by Youngquist and colleagues found that when they compare, and this is probably not surprising to anybody, but after 6 months, the skill decay was about 42% with endotracheal intubation, or sorry, 66% with endotracheal intubation versus BVM, which had a 42% skill decay, and even pronounced after 24 months. The same study looked at supraglottic airways, which showed less skill decay than endotracheal intubation. The other thing it showed was that even after a single encounter with a pediatric intubation event, providers felt much more confident in their abilities. But what we don't know is whether this confidence actually translates to actual skill and performance. So definitely, you know, just we talked about before about the approximately 30 intubations that are needed, and these are like live intubations needed to get competency in the first place from a novice, but to maintain that competency throughout the years can also be prohibitive for your agency, for your outfit, and that needs to be evaluated on an individual structure level. Next slide, please. And now we're on quality management. So basically, we're looking at, you know, what sort of quality measures are out there, what sort of benchmarks we can use to make sure that we have good and consistent performance in this arena, and how do we make sure that Cheng et al. In 2020 published 2020 published evidence-based recommendations for out-of-hospital pediatric respiratory distress. There's also the U.S. National EMS Clinical Guidelines. They advise for a PECC, a pediatric advisory for all groups. The PECC is a pediatric advisory committee, and also integration with local peds policy and procedures with the local pediatric hospitals, as well as awareness of the capabilities of your region. They talk about NAEMSP and Gamma QI and all these benchmarking goals, but because there is not adequate benchmarking, national benchmarking standards, they call for using evidence-based guidelines until those benchmarks are established. Let's go to the next slide. Here they talk about quantitative versus qualitative measures. Basically, you know, we are traditionally taught to really focus on quantitative measures of airway. Did you get the tube? How many times did it take to get success? Was there first pass success, et cetera, et cetera? But again, with that same stress now of qualitative success, was there early recognition of impending airway compromise? Was there the decision-making process necessary to prevent a invasive event, and was the appropriate interventions done to was everything done to prevent going down all the way down to the end of the pathway, essentially, and sort of using that as a bigger part of our evaluation of our competencies. They stress going through case review of every pediatric airway and respiratory distress encounter, with the medical director and having that go through the thought process with the clinicians involved. What were the symptoms? What did you do in response to the system? What symptom? What was your thought process? You reposition the airway first, then try supplemental oxygen, and using sort of this stepwise approach. They advise a rolling QI method instead of using it in block because of how infrequently this happens. That way, everything is fresh. And lastly, having the feedback shared with not just the clinicians involved, but with the entire system to share all that informational wealth. Lastly, we'll go over the evidence behind whether or not pediatric intubation is actually that useful in the field, but they basically go into saying the questionable utility of endotracheal intubation, pediatric endotracheal intubation in the field, and having that discussion or thought in your agency on whether or not this is appropriate for your outfit, and making sure that psychomotor practice, educational content, and cognitive decision-making processes are all taught on a quarterly basis. And that ends that part, and we'll go through the last paper here. You're almost there. I'm sorry, this is still qualitative. Sorry about, no, we're on to, yes, on the interventions. So they want to emphasize that appropriately sized equipment should be in every truck, compliance with regional and state national standards, and partnership with the local hospitals, especially pediatric specialty hospitals, to make sure that these standards are met. They go into end-tidal and talk about how things like high-frequency ventilation devices may make continuous end-tidal inaccurate in the pediatric population, as well as the device itself being relatively cumbersome in size for something like a neonate where extubation is a real concern. The more, we keep adding more and more things on top of the tube. Since COVID, you have the endotracheal tube, then you have the filter, then you have the continuous capno, then you have the PEEP valve on top. Like it's stacking. You're creating a tower on top of the endotracheal tube, and that's fine for most adults, where the tube is relatively secure in the airway, especially with modern day airway securement devices. But with small preemies or even neonates, it can so easily fall out, especially with just the extra length or weight of the end-tidal CO2 monitor. And it also increases dead space in premature infants, which may be a concern. And part 3, they go by blow-by oxygen and has limited efficacy in infants and young children, and really encourage the use of non-invasive positive pressure. This has been gone over, I believe Jermaine went over this already, but it can be used by, there's been some evidence that BLS, though not really in the pediatric world, but in the adult world, where BLS can be used to use CPAP and non-invasive ventilation, the adult side. So possibly having that implemented in the pediatric side may be useful, as it's been shown to decrease intubation in children. They also go over high flow nasal cannula and how in interfacility transports, it's been shown to decrease the need for intubation. And in their observational review of all these transports, none of these children who were stable on high flow nasal cannula on transport ever needed intubation en route. They go over chest rise, troubleshooting, appropriate BDM size, and also hand techniques, but prior fellows have already gone over that. I will skip over that portion of this. And if you can always read the position statement for more detail. Then they talk about supraglottic airway use. and that's the last part on this slide, and basically showed that it's much easier to train EMS clinicians to use supraglottic airways successfully than endotracheal intubation. Skill retention is higher, and in 2 propensity-adjusted reviews of pediatric out-of-hospital cardiac arrest, one in All Japan study, another by the CARES, showed no favorable difference in neurological outcomes in out-of-hospital cardiac arrest in subglottic airway use versus BVM use versus endotracheal intubation. While there has been other data, some mixed data that has shown some benefit of supraglottic airway over BVM. ILCOR in 2019 said it's reasonable to use the BVM as the main advanced airway in pediatric out-of-hospital cardiac arrest. In the end, it seems reasonable that using BVM, if it's a short transport, as recommended by PALS, or supraglottic airway, if there's not a ton, if your outfit does not have the capabilities of really training your paramedics to do proper endotracheal intubation in pediatric patients, it seems like a reasonable alternative on a position statement. Next slide, please. So here, this is, I guess Navin will have his, can talk about his opinion on this matter. Just based on what this paper goes over, they have stated that, New Mexico and California have removed pediatric intubation from the paramedic scope practice, leaving it only for critical care transports and flight paramedics. They cite the variable first pass success rate, rapid atrophy of skills over time, high complication rates, and infrequent performance and skill decay as the reasons why. There's no standard of education for this, and live experiences are lacking in this arena. In 2016, a study in Kings County in Seattle, Washington showed that paramedics got no more than 1 pediatric intubation every 2.6 years. Ghosh et al. Looked in LA, and based on their number of paramedics and the number of pediatric patients requiring airways, a paramedic would get an intubation once every 8.8 years. So it's the practice that you would get with adult intubation does not seem there for the pediatric side of things. You can look at pooled success rates. When they looked at pooled success rates of paramedics, failure rates happen from 14 to 50%, with decreasing ages, decreasing success rate as the patient age decreases, with major complication rates, esophageal intubations that were unrecognized, tube dislodgement, aspiration, pneumothorax, up to 7 to 11%. You'll see higher success rates in the critical care transports, first pass success rates of 60 to 78% in the literature, with overall success rates of 95%. So it seems reasonable to continue to pursue that in a critical care transport arena, but it's a much smaller group. It's with a much more emphasis on education and training, so that you can't necessarily apply that to all ground EMS and all other arenas as well. Then they go over pediatric cardiac arrest versus trauma versus stat epi, and they found this sort of the same thing. There is not a huge benefit of endotracheal intubation over using BVM or supraglottic airway in terms of neurological outcome and mortality. They go over DAM again, which Dr. Shah talked about, in which he already went on a very detailed discussion about, so we'll skip that. And lastly, again, ensuring competency if you are going to have your paramedics do pediatric intubations is necessary. And lastly, they do say that even if you decide to take that out of the scope of practice, the use of a laryngoscope with McGill's to remove foreign bodies should still be in every paramedic scope practice, as that is the only intervention that can be used if back back blows and abdominal thrusts are unsuccessful. All right, and that's the pediatric airway compendium in summary.
All right. Well, that was a big document to kind of go over. That's kind of why we took this extra time. Usually our journal clubs are only an hour. We do a case review. Thank you for everyone who joined us. Next journal club, which will not be this long, will be March 9th. So please join. If you want to be included in the invites, just go ahead and email me at the EMS Fellowship at rwjbh.org. And that is it.